Hello, my friends. Jill Osborne, IC Network. Excuse me. It is Sunday, January 15th. It is time for another live support group meeting. Now, I can tell you we are in between major storms. The next storm is imminent. And so if I disappear, it means either my internet has gone out or my power has gone out. So don't be offended. California is crazy right now. The weather we're having, I'm so tired of living between extremes. We're either in fire danger or we're in flooding danger, and it's making me crazy. Deep breath. Okay. So my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody telling you that this is all in your head. I don't want anybody telling you that you're damaged goods. I don't want anybody telling you that there is no hope or no treatments. Baloney. My job is to educate you, to inform you, to open some new doors, and then send you back to your doctor with a new set of questions, because obviously I'm not a doctor and I can't give you medical advice. Hello, Gay. How are you today? So I'm dealing with a sore throat. My tonsils are red and covered with white spots. It's not strep. My throat is not happy, which is why I didn't do my drop-in meeting on Thursday and Friday. So anyway, just bear with me here. Now, a lot of research is popping right now. And so it's really quite exciting what we're starting to see. We saw a new stem cell study, which showed that stem cell therapy actually was remarkably good at helping the bladder repair itself. We had a fabulous new paper from China. Hold on, it's right here. Okay, now y'all know you can never, ever doubt the power of patient voices. You can never doubt that, because they listen to us. And it's one of the cool things about my job is I get to hear language that I was the first to ever use slowly get used by other professionals, right? Now, in this case, this was not my voice. This was subtyping. Now, we, the IC patient community, you know what? Hold on a sec. I'm wearing my flipper. I'm just going to take it out. Hold on. I was making it hard to talk. Sorry about that, because, you know, I have a missing tooth that we're going to do an implant on. So back 20 years ago, we were saying, hey, doc, why do I have IC and IBS? Why do I have vulvodynia? Why do I have these other symptoms, right? And the doctors back then were saying, well, you have a bladder disease. You have a bladder disease. And of course, that wasn't quite good enough for us. You know, it's like, well, that doesn't really help me, because in addition to having a sore bladder, I have this really touchy bowel and I've got all these other things going on. And of course, we, the patients, we just wanted a doctor to help us with all of our problems, right? That's what we wanted. And listen, for those of you on Facebook, if you guys could share the link. And hello, YouTube. Nice to see you guys too. So, okay. So we were very assertive years ago that we had these other conditions and we could not connect the dots. Well, and then of course we had the big pelvic floor study that came out in 2008 or 2009, somewhere in there, that showed that unlike bladder therapies, which really didn't help a lot of people, pelvic floor therapy helped the great majority of patients who tried it. In fact, of the $100 million put into IC research, the single most effective study was not a bladder treatment, was a pelvic floor treatment. And as I've said before in these meetings, that's what put the IC world on its head, because up to that point, everybody's going bladder, bladder, bladder. And we're going, oh, wait a second. Well, if it was a bladder disease, why would muscle therapy help? Maybe it's a muscle problem for some of us, right? So that was a very pivotal moment in the IC world. And then slowly doctors started talking about subtypes. So it's like, okay, I mean, the doctors are not stupid. They could tell that some of us had muscle problems. They could tell that some of us had Hunner's lesions, but they could also tell that a significant proportion of us had widespread pain syndromes. So those of you with Hunner's lesions are very different than me with widespread pain, right? And of course, we're focusing on the concept of cause versus effect. I spent yesterday afternoon, I'm rewriting our website and I'm building it very, very differently. And one of the premier concepts that you have to focus on is the concept of cause versus effect, right? So about 5 years ago, we had subtyping proposed. Chris Payne, we were the first to embrace it, that there were distinct groups in the patient population: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization, right? And when he put that proposal out, he met with silence. He met with silence from, the other IC researchers. Until this year. Till last year. Last year, when the National Institutes of Health convened their IC meeting, which I was at, they finally went, okay, you've been right all along. They're distinct patient groups. And not only are there distinct patient groups, but they each have their own treatments. So now we know why so many of you who did bladder therapies haven't gotten better, because obviously I was working with a patient last week, completely healthy bladder. She was a ballerina, and ballet is a very big risk for pelvic floor dysfunction. So, and she'd never had a pelvic floor assessment, sent her off for that, right? So anyway, we now have consensus really here in the United States that we have distinct patient groups. And yeah, some of these groups are going to be refined. There'll probably be a few more added, but we're moving in the right direction. We're moving in the direction of precision medicine. That means before we give you treatment, we need to understand what group you're in, because we don't want you to waste 5 or 10 or 15 years doing something that has no chance of helping you, right? So anyway, as my colleague Jane in Europe sent all the IC groups this article, or a link to this article, which came from China. We've never seen anything like this before. The Chinese researchers, for the most part, have been. They've been very productive. Make no mistake, they've been very, very productive, but they've been very, very distant. I think that's fair. Anyway, this is an absolutely brilliant article. Brilliant article. It reviews all of the history. It reviews all of the guidelines. It reviews the subtypes. And in the end, I love this article, and I will post this on our website. Like literally, they have every treatment listed and which guidelines include it, from all around the world. So it's Canadian Urology Association, American Urology Association, European Urology Association. It's fantastic what they've done with this. So I'm going to have a lot more on this. But anyway, the images also are just exceptional. I wanted to read this summary for you here. Hold on. It's a really long article. Okay, let me just read this to you. We have summarized the advancements in the diagnosis, treatment, and fundamental research of IC and set new directions for clinical and scientific studies and investigations. Due to the complexity of IC, treatment is no easy task. A promising trend is multimodal therapy targeting identified phenotypes, right? This is exactly what we're talking about. We don't want you to waste time doing treatments that are not just relevant to your unique case. And ultimately, in the end, what does this mean? This means that, guess what? IC is not an incurable bladder disease for probably the great majority of us. It is not and as our guidelines say, there is no disease process happening. Disease process, guys, bear with me. I have a sore throat. There's no disease process happening in most IC patients. It's not a disease. There are other things going on, often injury, trauma, estrogen atrophy, and things like that. Okay. So anyway, I will have more on that. It's been a little bit hard to for me to concentrate because I haven't felt well the last couple of days. So I've been kind of stepping to work and then stepping back and stepping to work and stepping back. The other thing that I did share on all of our channels is this fascinating study that came out that compared the experience of men and women diagnosed with IC. And this comes as no surprise. Hi, Donna. Hi, Sandy. Hi, you guys. It comes as no surprise that women diagnosed with IC feel disregarded. They feel ignored. You know what that's like. I mean, come on. This is not new. We've all been through this. We've all shown up at the emergency room and had somebody roll their eyes and go, it's all in your head, or what are you doing? You ask you for pain meds, stuff like that. It's absolutely fascinating, the difference with how doctors engage with their patients, because for the typical female IC patient, when we work with our doctor, we often feel ignored. However, the men with IC felt involved and supported. I thought that was quite interesting. I mean, again, it doesn't come as any surprise, but it's nice to see it in writing, because we now have to have doctors think about them a little bit more. Think about how they're working with their female patients. Donna is on her way to Europe to see her son. Donna, this is a hug now. Girl, you're the boss. You're the bomb. You're strong. You're prepared. You're informed. You're determined, and you're passionate about your son. Get yourself on that plane and get on out there. And I'm sending you my love, hon. I'm so sending you my love. Big, 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 giant hug to you. Hi, Sandy. Nice to see you. All right. Anne says, dreading colonoscopy prep this week. Probably would have a lot of frequency. Any tips? Well, and there's good news. And that is, in fact, I have an article on this on our website. Colonoscopy preps really are not known for irritating IC. And I think the challenge here is that, again, we have to think about what is IC for a moment. We have subtypes. So if you have Hunner's lesions, God, my voice is definitely struggling here. If you have Hunner's lesions and you pour acid on a lesion, that could be irritating. That will be irritating. So if you're going to do something like go lightly, make sure you don't get the citrus flavor. Get a non-citrusy flavor, or better yet, do the Miralax protocol. The Miralax protocol is 4 biscotal pills, and then it's Miralax dissolved. You can dissolve it in water. You can dissolve it in pear juice. You can dissolve it in Gatorade, something like that. That's what I did 10 years ago when I had mine. But I don't know if you heard, they have just released now. We have a new colonoscopy prep that is just pills. You don't have to drink anything. You have to swallow a lot of pills. I think it's like 20 pills or 15 pills or something like that. But you could ask for that too. So I think the biggest challenge, again, I have no shame. I'll talk about anything. When you're in the purge, your pelvic floor is going to get a little bit on the sensitive side, right? Because you're basically cramping. You're basically letting it all out. And so using a heating pad, I think, would be very smart to get you through that. I know with the Miralax protocol, they say to do half the night before and half 4 hours before the test. Well, my test was at like 9 in the morning, which would have had me get up at 5 in the morning. And I knew at like 10 o'clock at night that I wanted to get some sleep. And so I just did it all the night before, and I was fine. And so talk to your doctor about some of that. Anne says Miralax prep for me. Yeah, Miralax prep is fine. If you're going to do Gatorade, just get 2 flavors. You can get the green, you can get the blue. You just can't get the orange or the red. Hello, Dana. Hello, Judith. Hello, Becky. Becky says, IC flares to me look like a fluttering bladder, like cramping low down, urethral pain along with urgency to pee. But the worst part is the extreme burning of the vulva area. I'm forever cognizant of the discomfort in my urethra. So Becky, how old are you, hun? I see in your portrait here, your thumbnail here, that it says 1962. Well, I'm 1960. I was born in 1960, which means that I am 62 years old. So that urethral pain and the vulvar pain is most likely estrogen atrophy, hon. It happens. It happens. When that bladder wall does not have enough estrogen, when the urethra, when the vulva, when the vagina do not have enough estrogen, what happens is they dry and you start to lose that nice thick protective coating that acts as a barrier and is protective to the skin. And so if your vulva is dry and your vagina is dry, so is your urethra, so is your bladder. And that urethral pain, the urethra is kind of the canary in the coal mine when it comes to estrogen atrophy. It's a first part of the urinary tract to start screaming. And that's what happened to me. It was 51 when it happened to me, or 52. And it felt like there was a drop of urine stuck in my urethra that would not come out. And I've shared this story many, many times where, you know, guys, my IC self-help skills are obviously really, really good. I wrote the IC network. I know what to do. So I had this new urethral pain and I'm like, what do I do for this? What do I do for this urethral pain? 3 months in, nothing worked. I threw myself on the mercy of my urologist, who took one look and he goes, Jill, did you use the estrogen cream I prescribed for you? And I went, no. And he goes, why? And I said, because in my heart, I'm 25 years old. And I can't possibly have an age-related issue, which got him laughing. And then he goes, well, I was trying to prevent this from happening because I saw this happening last year. That's why I prescribed it for you. And that topical estrogen made it all go away. Made it all go away. You know, it's like I'm having to work to talk. It's like the back of my throat and my palate, it's been this way all week. It's better because it was down here. Now it's just really focused right here. So it's definitely getting better. But it's annoying. Becky says, absolutely, breast cancer survivor, home run blockers. So Becky, if you look at the latest research, topical estrogen, not oral estrogen, topical estrogen has been found to be very safe, even for estrogen-driven cancer patients. I would encourage you to Google it. Topical estrogen safety, estrogen. The newest research is really quite promising. And in fact, I swear on my Twitter feed, there's a couple of doctors you want to follow on Twitter. Twitter is kind of where the doctors hang out. And it's sad because Twitter is kind of a cesspool right now, which is really sad. And so I think everybody is slowly migrating away from Twitter. I'm going to go to Spoutable when that gets active. But hold on a sec. Now, and this computer is being really weird. You want to follow Rachel Rubin, Dr. Rachel Rubin, Dr. Ashley Winter. Sorry, that was weird. Rachel Rubin, Ashley Winter, Jennifer Gunter, Dr. Jen Gunter. These are all kind of the leading OBGYNs are really moving us forward in a much better direction. Because the challenge of you being on hormone blockers is that, as you know, you just age massively. I mean, everything gets dry. Everything gets dry. And the skin is meant to be moist. When it's not moist, think about dry mouth. Dry mouth hurts. Dry mouth hurts, right? Well, dry vulva hurts. Dry urethra hurts. Dry bladder hurts. And the advantage of topical estrogen is it stays in the skin. It does not disseminate throughout other parts of the body. So the research really in the last 5 years is quite promising. But talk to your doctor about it. You need to Google it and look at it and see what you're comfortable with. If you choose not to do the estrogen, then you're definitely going to want to keep that skin moist, maybe with some V Magic or some coconut oil, especially before you pee, because we got to get that barrier in there. It's the irritants of urine getting through that dry skin of your vulva. That's why you're having that heat, that hot burning sensation. So if you could put V Magic coconut oil on your skin ahead of time, then urine cannot get into that dry skin and bother it. Hold on, I think I have my V Magic. I swear I just found it. Oh, I did. Here it is. So, this. Oh, that's so funny. All right, hold on. Okay. Sometimes my foot hits my seat and it drops all the way down. Okay. V Magic. Medicine Mama's V Magic is very, very popular among women who cannot do topical estrogen for one reason or another. Okay. And it's made of extra virgin olive oil, extra virgin avocado oil, honey. We'll come back to honey, sea buckthorn oil, propolis, etc. And so I was working with a patient again recently who absolutely loves this stuff. It looks like see, the lights are really bright. Can you kind of see it? It's just an ointment, right? It feels kind of like Vaseline, but it's not sticky like Vaseline. So you can get this in the IC Network store. V Magic. V Magic. Jude said, is it safe to do the topical estrogen and the V Magic? Yeah, absolutely. Absolutely. There's no reason why it shouldn't be. Sandra said, sorry to hear about your throat. Looking for a doctor and physical therapist near New Hope, Pennsylvania. Is there a phone number where you can be reached? Yes, it's on the front page of the IC Network. 800-928-7496, and a website you can go to. We have a database on our website of doctors, but if you're looking for a physical therapist specifically, go to pelvicrehab.com. Pelvicrehab.com. That's the database I go to. This is good stuff. It's interesting. It's interesting. I like coconut oil too. The challenge with coconut oil is that it gets very greasy. And so whatever you do, don't put a coconut oil and then wear dark pants or a dark dress and go to work. Because the coconut oil, if you're wearing cotton underwear, is going to seep through everything and you'll end up with a dark spot. You'll end up with an oil spot on your clothes. Donna says, take care of yourself. Man, I'm trying. Palm says, TheraWorks Protect Wipes are made for urinary problems. You know, I've been using, they're called water wipes for my mom. And those are really working really well for her too. Katie says, I have Hunter's lesions. I took Cytocheck for 2 days before, ordered by my urologist, and Senna tabs were also recommended. Oh, is that for the colonoscopy? Senna is a stimulant, and so the challenge with things like Senna is that they stimulate the bowel and they cause it to cramp, which then causes you to eliminate whatever in there. But it can be quite addictive, not emotionally and psychologically. It's just if you keep using it, you start messing with the nerves of your bowel and your body becomes a little bit dependent on it. And so you got to save Senna for very, very, very rare use, like, you know, a colonoscopy. Otherwise, it's not a good daily thing to use. There are Senna teas for bowel movements. You definitely don't want to do those. Who is Dr. Gunther? Dr. Jen Gunter is the author of the Vagina Bible and the Menopause Manifesto. And let me see, I think I have them right here. Here they are. Oh, stay. Okay. So, for those of you who are just a wee bit younger than I am, back when I was a kid in my 20s, the book that our moms gave us when we were teenagers and in our 20s is a book called Our Bodies Ourselves. Our Bodies Are, I'm going to sneeze. Hold on. And so, inevitably, on Christmas morning, in addition to the obligatory underwear and socks gifts, every girl usually got a copy of Our Body Ourselves. Well, there's a new one. Instead of Our Body Ourselves, it is the Vagina Bible. Oh, wait, hold on. It is this one, the Vagina Bible. This book is fantastic. It goes over everything you possibly need from uh, uh, what are the right soaps to use. In other words, no soaps. She goes over douches. Should you do them? Should you not do them? Very practical, very blunt, very direct. She talks about proper menstruations. Should you use tampons or pads, and what are the pros and what are the cons? Toxic shock syndrome. She talks about sex. She talks about vaginismus. She talks about infections, how to prevent sexually transmitted diseases. Let me tell you, if you got a young kid, oh, like, I love her. I love her. She's like a total role model for me, even though we're the same age, because she's very bold and in your face. She's not afraid to tell somebody to shut the F up if they're being ridiculous online. I mean, there is no pushing that woman down. She's a great, in my opinion, role model for young women to stand and let their voice be heard. Anyway, like here's chapter 40. Oh, I have vaginitis. What is vaginitis? What is a normal discharge? What is an unusual discharge? She talks about pH. She talks about the microbiome. She talks about, oh, look at this. Here's another chapter. I have a vulvar itch. So rather than going down and spending hundreds of dollars for Monistat, maybe learn a little bit about it. Oh, I have vulvar pain. I love this one. I have an odor. So having at least one copy of this book in your home is and if you have, for you and also for any female relatives, great. But I'm telling you right now, it's a great birthday gift and Christmas gift for women, young girls. It'll just embarrass the hell out of them, but in the end, it will be very useful. The other book that she wrote that is also just incredibly important for those of us who have had hysterectomy, who have been on Lupron, who are in our 40s going through perimenopause or menopause, is this one, the Menopause Manifesto. Because you know what? Nobody teaches us this stuff. Nobody teaches us what to look for. One of the things that happened to me in my 40s is I went through a period. Well, number one, I started waking up really anxious, free-floating anxiety, which is very common with perimenopause. You would think that your ovaries would just gradually shut down. They don't. What happens is they get very random. And so you have massive spikes of estrogen, and then you go up and down, up and down. And it's these big swings in estrogen levels that drive these crazy symptoms. And so you can feel very teary. But what happened to me is I just got really angry. I had moments where I literally wanted to slug the next person that I saw. And I'm not a violent, I've only hit one person in my life, and that was Pam, who put her horse where my horse was when I was a teenager. She's the only person I've ever hit in my life. And I think she hit me first. So here I am shopping, and I literally wanted to slug the next person who walked down the aisle next to me. And of course, I never did. But it scared me because I'm not a violent, aggressive person. And bam, I wanted to hit something really hard. And then you ask yourself, why am I angry? And there's no reason. And then it's gone 10 minutes later. It's like totally gone. It's like, what the hell is this? It's called the rages. And it's very common with perimenopause. It's just a hormone swing. just a hormone swing. And it lasted for me for a couple, maybe 2 years, 2.5 years, where just, once a week or so, I just get, Urgh. So you got to understand with your family, you might do that. And they're going to start looking at you like, woo, mom, back away. What's wrong? And you got to take that deep breath and center yourself and go, ask yourself, why am I angry? You're not. You're just having a hormone swing. Okay, hold on. I need a drink. This is honey tea. This is the bomb. This is hot water with manuka honey and a little tiny bit of lemon. And then I have my normal smoothie, but the cold is kind of irritating my throat. Okay, that was better. Okay, good. Samara says, I'm 50 with a Marina, and I've had no symptoms of perimenopause. Girl, it'll happen. For some women, it starts when they're younger. For others, it starts when you're older. It's going to happen eventually. Hello, Carol. Carol says, nice to be here, and you are live. Woohoo! Hope your holidays were great. They were. Palm says, Jill, you are amazing. Just want to thank you. You're very, very welcome. You're very, very welcome. I love my job. I do. I love my job. Becky says, doctor wants to talk at the next appointment about pelvic floor therapy, internal muscle stretching. I'm so afraid of it setting off an IC flare. Girl, Becky. Oh, do not be afraid of physical therapy, my dear. Physical therapy is really exciting because it's the first treatment in history to ever heal people. Remember when I started back, when I started this, I talked a little bit about history and how for many, many years, we thought IC was an incurable bladder disease, but we knew over 10 years ago that for the great majority of us, 85% of us, 85% of us actually have muscle problems. And our new guidelines say that IC is not an incurable bladder disease. IC is a neuromuscular disorder. It is a pelvic pain syndrome. And so it's really encouraging and exciting to go to a physical therapist first for a pelvic floor examination, because we need a new set of eyes at your body. If you're not responding to bladder therapies, if you're getting worse rather than better, then we need to take a step back, revisit the diagnosis, and see if what we missed. What have we missed? Have we missed anything? And for many of us, we have missed tight pelvic floor muscles. So when you go to that first appointment, they're going to do something called a pelvic floor assessment. They're going to look at your, with your clothes on, they're going to have you walk up and down a hallway. Let's see if you're walking correctly. They're going to, and you never walk in to a physical therapist and say, I have IC, fix me. You walk into a physical therapist prepared to talk about your symptoms, because you have to give them a map of what to look at. It's also, so if you have pain on the left side, if you have pain on the right side, you have pain that shoots down your leg, do you have pain in your lower back? Is there anything weird going on? Do you feel like you're sitting on a phone on vibrate? Is there a vibration? What makes your pain worse? What makes your pain better? Are you even having pain? Are you just having frequency or urgency? Anyway, your ability to describe your symptoms gives them a roadmap. So don't just walk in and say, I have IC. That's a mistake. You need to walk in and describe your symptoms. And we want a separate set of eyes studying your pelvis. So they're going to, and remember, your pelvis is a very small confined area with a lot of stuff happening. You got your urinary tract, you got your reproductive tract, you got your your bowel and all that sort of stuff. You got big nerves down there, and you got big muscles down there, your pelvic floor muscles. So they start externally. They're going to measure the length of your legs. Do you have one leg longer than the other? They're going to look for scoliosis. I have scoliosis. That's one reason why my muscles tend to stay a little bit on the tight side. And then they will ask if they can do an internal exam. Don't freak about it. It's fascinating. It's absolutely fascinating. You're not in stirrups. It's nothing like that. You're gonna wear a gown. You're gonna be laying on your back. Your knees are gonna be open just a little tiny bit. She's gonna be loved, a little bit of KY. She's just gonna stick her finger in there. That's all. And what she's gonna do is touch muscles. Let me get my model here. All right. Let me get my model here because I really want you to understand why this is so important, right? Okay, so here's your pelvis from the front. So we got your pubic bone, your pubic symphysis, right? Get your hip bones. If we turn it around, got your vertebrae from your spine. We've got your sacrum, which is a bunch of huge vestigial vertebrae. And of course, we have the all-important tailbone. This is very, very important for us because I want you to look at everything that attaches to the tailbone. We have a lot of muscles that attach to the tailbone. So a lot of us have tailbone injuries. A lot of us. My symptoms started after I broke my tailbone when I was 14. Okay? But now we have to look at it from this side. So the thing about the pelvic floor muscles is it's very hard to reach them from the outside. And the other thing I want you to think about your pelvic floor hair is, do you see how flat they are to the bone? They're normally flat. They're normally around the perimeter of your pelvic floor. But when they get tight, what happens is they lift up and they start interfering with all the other bits and pieces that are in there, right? So these are your classic pelvic floor muscles from the inside. And then from the outside, there are 3 layers of muscles. So think about your knuckles. You've got shallow muscles, medium muscles, and deep muscles. So I'm going to put on the levator muscles. These are the shallowest muscles right here. And yes, my model is broken. What makes these muscles all the more interesting in the human body is that they're the only muscles in the human body that also control major bodily function, because essentially they have 3 holes in them. They have a hole for the rectum, a hole for the vagina, and a hole for the urethra. So if these muscles are tight, what happens? Oh, look at that. They squeeze the rectum, they squeeze the vagina, and they squeeze the urethra, which is why constipation is a symptom of tight pelvic floor muscles, why pain with intimacy is a symptom of tight pelvic floor muscles, and why difficulty starting your urine stream. If you hesitate 5, 10, 15, 20 seconds before you can release urine, yeah, that usually means that your levator muscles are tight. Okay? I'm going to take these off. Now we're getting to mid-level muscles and deeper muscles. So let me see if I can demonstrate what the pelvic floor physical therapist is going to do. They're going to have their finger in your vagina, and all they're going to do is touch muscle groups. They're going to be shallow, medium, deep. They're going to touch muscles over here. They're going to touch muscles here, here, here. You see how easy it is to reach these muscles? It is very easy for them to reach these muscles. If they touch a muscle and trigger discomfort, that is what I call your hallelujah moment. It's like, oh my God, you found it. What are you touching? What are you touching? You know, when I work with patients, I spend a lot of time trying to understand your pain, because see, the challenge is that for a lot of you, you don't think about your pain. You're just in pain. So I ask really tough questions like, okay, where is the pain located? Well, it's down there. It's like, where? Well, it's down there. No, I need you to be really thoughtful. Where is it? Is the pain on your skin, on the outside? Or is the pain inside of your body? They're like, oh, hadn't thought about it that way. And quite a few women, they don't know. I mean, literally, if I ask them that question, they're like, I'm not sure. Okay. But let's just say it's on the outside of the body. If it's on the outside of the body, we're looking at skin every single time. That's probably estrogen atrophy. But if we're dealing with pain on the inside, my next question is, okay, where do you think the pain is located? Is it in your urethra? Is it in your vagina? Is it in your rectum? Or is it in your bladder? And it's amazing the number of patients who were never asked that question. And again, I was working with a patient like on Thursday or Friday. Her pain was entirely vaginal, entirely vaginal. And yet she was diagnosed with IC. And I was like, well, you do realize that's not your bladder. And I asked her, I said, okay, do you have pain as your bladder fills with urine? And she said, no. Then what did that tell us? That tells us that her bladder wall is healthy. I think they'd done a cystoscopy. Her bladder wall was normal. What she had was vaginal burning. And so that was either from estrogen atrophy or that was from tight pelvic floor muscles or perhaps something else like a fibroid tumor. Okay, so, and then I'm going to ask questions like, okay, what makes it better? Heat, ice? If heat makes you feel better, that points us to muscles because heat relaxes muscles. If heat makes it worse, but ice makes it better, that points us to nerves because nerves like to be calmed by ice. And so anyway, I spend a lot of time. I literally will talk 20 minutes just about pain. For those of you who have called me, I say I don't want to talk about treatments. We have to talk about your body first. It's pointless to talk about treatments until we understand what your potential subtype is. Okay, so anyway, getting back to the pelvic floor exam, if she can touch a muscle and trigger your pain, that is very, very exciting. And your immediate question is, what are you touching? And I want you to be able to walk out of that appointment with the names of the muscles that are the problem. Because again, for many of us, it's injury, it's trauma, whether you sustained a pelvic trauma from having a baby, if you were, sadly, I was working with another patient who was abused, and I want to talk about that. She'd been abused. Still others, a lot of you have broken tailbones, things like that. And ultimately, in the end, the bladder is being victimized by poor blood supply from tight muscles, right? And so that's why you have bladder symptoms. Bladder therapies won't work for that patient. You'll chase your symptoms for decades. We want to fix a problem. We have to restore blood supply. And the way we do that is with pelvic floor physical therapy. So anyway, the goal here is to walk out of that appointment with the names of the muscles that are messed up. And listen, if your pelvic floor is normal, good, then we can move on. If you have a physical therapist who says, I don't want to do an internal exam, we're just going to do Kegels, that is a physical therapist who's not trained. You need to make sure that you go to a physical therapist who has taken proper pelvic floor classes, preferably if they're certified in pelvic floor work. So anyway, for me, it was my left piriformis muscle was my dominant problem. And physical therapy was just stunningly successful. I mean, I did bladder therapies for decades. They never worked. And I kept getting worse and worse. And then I was having trouble sitting. And I went from being able to sit here at the IC network for 5 hours to being able to sit for 5 minutes before my butt cheek would start vibrating and I'd have pain sitting. That continued to get worse, no matter what they did. Well, because guess what? I actually am not a bladder wall patient. I am a pelvic floor patient. And pelvic floor physical therapy has given me my life back. And again, of all the therapies ever studied by federal researchers, the single most effective study is the pelvic floor study. And again, understand that 85% of IC patients have messed up muscles. And that for men, that's you too. For the great majority of men, I'm going to go right out there and say, I think 95% of the men with chronic prostatitis and or IC actually have muscle injury. Palm says, if you have pain after a bowel movement, what muscle group is that? That's levator, and that's your pelvic floor. Donna says, what's my smoothie? My normal smoothie is, what was it this morning? Ice, peach coconut yogurt, frozen bananas, frozen mangoes, 1 or 2 strawberries, acacia fiber, water, and then coconut milk. Sometimes I'll throw some coconut in there too. That's good. This is breakfast and lunch, guys. I usually don't have time to eat on Sundays. I'm madly getting my parents up and fed. Have you heard of Singulair being prescribed to help bladder inflammation? Singulair is an antihistamine, right? Let me make sure I get it right. Yeah, it's an antihistamine for allergies. Well, so let's see. I have a great picture I could show you as to why that would be useful. Let me see if I can find it. Hold on. Let me see if I can find this picture. Hold on. Is that look at that. Here it is. All right. All righty. Are you okay? You guys, I love Mama Tot on TikTok, even though I've deleted TikTok. I love Mama Tot. She Lover 99 because she'll just spend time with you. And one thing she does, she just will sit down and say, let's just have a snack and let's just talk. Are you okay? Because if you're not, I'm here for you. And I care about you. And I want to try to help you. And I love her. And so I'm going to try to embody Mama Tot when I do these meetings. All right. Hold on. Let me see if I can find this picture. Yeah. Okay. Okay. So we're going to be a little nerdy right now, but just bear with me here for a moment. Back in the old days, we all thought that IC was a problem with the bladder wall. In fact, the name interstitial cystitis, which we now know is the wrong name, implies a problem with the interstitial layer of the bladder. We know that that's wrong. But let's say you've gone through chemotherapy and the chemicals of the chemo have damaged your bladder wall. Because the bladder can be hurt. Like any other part of the body, the bladder can be hurt, and it's usually hurt through some sort of chemical exposure. Or let's say you're a big diet soda drinker, not understanding that NutraSweet is metabolized into formic acid, formaldehyde, that's going to cream the hell out of your bladder wall, okay? So now we have a wounded bladder wall. Oh, and I printed out a whole bunch of new pictures. Oh, of bladders. Ooh. And I didn't print them out. I mean, they're on my computer, but they're not printed out yet. So we now have the equivalent of a skinned knee in the bladder. You know how when you fall and skin your knee, you got a lot of little tiny wounds in there? Well, that's what happens in the bladder. You can have a lot of wounds in the bladder, okay? And so that happens. That certainly can happen. So what happens? So, and you're not going to be, you're probably not going to be able to read this. But, okay. So here is, we have a bladder insult. We have a bladder wound, okay? And so we have epithelial damage. We have damage to the skin. Now, because the skin is damaged, urine is going into the wound and potassium is going into the wound. So what happens when urine and potassium goes into the wound is you get an activation of nerves. The nerves get triggered. The nerves get irritated badly. So that's why the first symptom that you feel is usually frequency urgency, because that's the nerve that is pervasive in the bladder wall. That's a nerve that works 24 hours a day to tell you when you need to pee. So now we've got urine that's entered the bladder wall and it's hitting the alpha afferent nerve. And that, of course, is giving you frequency urgency, right? So, the other thing that happens when you have an irritated nerve is that nerve releases damaging substances, specifically substance P. Yeah, well, that's what it says down here. It releases substance P. And substance P is very irritating. And so now not only do we have urine irritating the tissue, now we have the nerve itself releasing stuff, which is very, very irritating. That then causes mast cells in the area to release histamine. And of course, histamine is also very irritating. If you ever get a mosquito bite, the mosquito injects venom. The venom irritates the nerves and irritates the mast cells. The mast cells release histamine, and that's what causes the skin to get red, to get swollen, and very, very itchy, right? So what happens is you get stuck in this vicious loop. Many of you are living here. You're just living here. The bladder wall's getting irritated by that 1 cup of coffee a day. The nerve is being tweaked, triggering the mast cells. The mast cells are releasing histamine, which is now irritating the nerves even more. And you are stuck in this vicious cycle right here. So the way to get out of this vicious cycle, you can get out of it 2 ways. Number 1, you can use a low-dose antidepressant, not for depression. Don't be offended if a doctor says, you should do an antidepressant. It's because it calms nerves down. So we can do the low-dose antidepressant to go ahead and calm that nerve down to get it to stop releasing substance P, or you can do an antihistamine. And it's a 2-pronged attack. Doctors will suggest the low-dose antidepressant, and they might suggest the antihistamine. So one blocks one part of that vicious cycle, the other blocks the other part of that vicious cycle. The challenge, of course, with doing that, there are several challenges with that. Number 1, a lot of side effects, antihistamines, dry mouth, dry eyes, irregular heart rate, and a significant risk of cognitive decline and dementia if you're using it every day. I think if you use it for 3 years every day, there's a substantial risk of cognitive decline. So we certainly don't want to do that. And the antihistamine that we commonly use, hydroxyzine, is also an anticholinergic, which also carries the same risk. So there's a trend kind of to move away from that. That's why supplements are so popular now, because they don't carry those same risks. But ultimately, doing an antihistamine, doing an antidepressant is what I call chasing your symptoms. They're not going to fix anything. They might make you feel a little bit better, but you have to be laser focused on cause. So if, for example, your bladder wall is vulnerable because you have estrogen atrophy, then the single most important thing for you to do is try to fix the skin. When we fix the skin and make the skin healthy, then you're not going to have all these symptoms. And that's why topical estrogen is so important. But again, the other thing we have to look at for many of us is the bladder being compromised by ischemia, decreased blood supply because of tight muscles. And if that's the case, you're never going to have a healthy bladder as long as you have tight muscles. If your bladder is supposed to get 24 units of blood a day and it's only getting 10 units of blood a day, are you going to have a healthy bladder wall? No, you're not. And again, using the antidepressants and the antihistamines, yes, you might feel a little bit better, but you'll never fix it, because the underlying problem is not a bladder wall problem. The underlying problem for these patients actually is poor blood supply because you have freaking tight muscles, right? So cause versus effect. You need to be laser focused on underlying cause. When you go to the doctor, don't walk in and say, I need a new treatment. This isn't working. Instead, what you're going to say is, okay, doc, we've done this for 6 months. I'm not any better. Let's take a step back for a moment and let's make sure we haven't missed something. And one of the things that a lot of you guys forget to do is you forget to tell your physical therapist and your doctor about trauma. Have you had a bad fall? Were you in a car accident? Did you have a difficult delivery? Have you ever broken your tailbone? Or tragically, were you a victim of abuse? For some patients, and I'm telling you, I talked with my twin this week, my absolute twin in terms of our presentation of IC. And we are in IC subtype 5, central sensitization. For me, a pivotal event was breaking my tailbone, which massively messed my muscles up. And of course, back then, you guys remember, your bladder only knows one language: frequency, urgency, pressure, pain. Everything feels like UTI. A bullet wound feels like a UTI. A stab wound feels like UTI. Cancer feels like UTI. The only way the bladder can tell you that there's a problem is by giving you the symptoms of a UTI. But for the great majority of us, there's no infection. It's injury or trauma. And back when I was a kid, when I was 14 and I broke my tailbone, of course, I had massive antibiotics. They never worked. I was also diagnosed with a urethral stricture. It was like trying to pee through a needle. And back then, what they did is they forced the urethra open with a metal rod. It's called a urethral dilation. I had about 100 of those. I had them every week for almost 2 years. Now, let me tell you, actually, a doctor at a recent IC course, an international doctor asked the American panelists, "Do you do urethral dilations?" And the American went, "We don't rape the urethra anymore." That's what he said. We don't rape the urethra anymore. My urethra was raped 100 times, easy, when I was in junior high. And the mistake that they made is that they didn't go, oh, wait a second, why is her urethra tight? Here's the urethra. Here's the muscle. The urethra is tight because my freaking pelvic floor muscles were tight because I had broken my tailbone. Remember, look at everything that attaches to the tailbone. And I got scoliosis that year too. And so one of my hips is like rotated slightly forward, which also would have put pressure on that. I want to take a moment though and talk about my twin, because the best part of my job is when those people call me and they have never understood their life. They didn't understand why this happened. They didn't understand why they had bladder problems and then bowel problems and then super sensitive skin and then a wicked sense of smell. And in her case, and if you're watching this, hon, you are so strong. Remember your strength. You have never been more prepared to deal with whatever happens to you than you are at this very moment, because you are one day older and one day wiser. But there is a harsh reality here, and that is childhood trauma plays a role for some of us. So you think about that young girl or that young boy who was raped. And back then, listen, I'm sorry, but for my generation, rape was common. Literally, I was rescued from a guy when I was back east. If I hadn't been rescued, I would have been, all of my friends, my tennis partner was gang raped. I mean, they went to court and everything. It was terrible. Absolutely terrible. Think about that young girl or that young boy that happens to, especially if it's pervasive. they are going to subconsciously tighten their pelvic floor muscles, right? Because you don't want this to happen. When you're afraid, your muscles get tight. So we have a child that's been afraid for years. And then as they get sexually mature, they try to have sex. Oh, hell no. It hurts bad because their muscles are locked down tight. And these women are also, they dread going to the gynecologist because putting the speculum in is agonizingly painful. And for some of you, it's so painful, you can't even get a finger in there. Believe me, your muscles are locked down like a rock. And I'm so sorry that this happened to us. I understand implicitly the isolation, the depression, the self-condemnation that happens. But you are not alone. And it was not your fault. There is no shame and there is no blame. When we're a kid, we don't know that. We are 60 years old now, 50 years old, 40 years, 30 years old. We understand implicitly that when you are a victim of violence, it says nothing about you. It is a power play. It is a power play. And we are not going to let anyone do that again. The gift, and I said this to her, the gift, and there is a very important gift that happens. So you will never, ever, ever walk away from any other person who is sexually violated. There is somebody out there who will need you. And I want you to reclaim your power. I want to swear right now. F them. F them. You are a strong, capable, independent woman today. And if you need to talk about it, then we got to get into a support group. We got to get into it's sexual violence is pervasive. No shame. There are other people who've gotten through this who will help you. And it is very important that you let this out. It is with help, with professional help. And having a sister by your side or a brother by your side, because believe me, this happens to boys too. And we want to address the suffering. Because in the end, it's done, it's over. And we don't want to live there, and we don't want to give them the power over our lives by living there. It's done, it's over. And we can't worry about the future because the future has not happened. What do we have right now? It's today. What can we do today to put our heart and our body and our soul in a better place? What can we do? Well, you've been to a support group meeting. I hope when you come to my meetings that I make you feel better. I hope I give you a chance to just get a hug, even if it's online. You're not alone. This is not your fault. And we've got answers now. We've come so far. But that childhood trauma is important, and I smell something burning. Excuse me. I will be right back. Whoa. What's going on? What's going on? I'm just going to grab this for a moment. I'll be right back. You guys, I care for a 100-year-old and a 94-year-old. You never let the 94-year-old use the toaster. This is what happens. I'll be right back. You know, when I was in my 20s and really dealing with severe IBS, severe anxiety, everything, which of course we all now know relates to the trauma that I went through, I didn't think that I'd be a good mom. Honestly, I didn't. I could barely get through the day myself, much less care for anybody else. And anyway, this is what I now know is I'm a great mom. Only I'm a mom to a 100-year-old and a 93-year-old. All right, let's get back to your questions. Sorry. Palm on YouTube says, I have Sjogren's syndrome. It involves destruction of mucosal linings in the body, so this I can relate to. Exactly. All right, here, Facebook. And you guys, I don't know. I did wash my hair today, but, you know, there's all the storms make my hair all fuzzy. Let me just put my hair in a ponytail. Hold on. Carol Ann said, been at the urologist, says no cancer, no infection, but still had pain on the left side of pelvic for weeks. Wants me to have my lower back for an MRI. Good. I think that that's great. Okay. This is, well, I don't know. All right. It is what it is. This is what you get. Okay. I think it's fantastic that they want to do an MRI, hon. Absolutely. I would absolutely do it. The thing about an MRI is that, I mean, you've got a CAT scan versus an MRI. A CAT scan is very quick, literally a minute or two, you're done. An MRI, magnetic resonance imaging, involves you being in a tube, and it's about 20 minutes. And it's really loud. I just had one for my lower back last year. And so if you're claustrophobic, MRIs can be challenging. MRIs, it can be a narrow tube where you're laying in it and like literally it's right here, or it can be a big tube. Big tubes are better. Big tubes are better. And may I just suggest a little bit of Valium beforehand to get through it? What I did with my MRI is I did my I Spy, my body technique. I did my chakra rotations, which we can talk about at some point in time. I know it's weird, but I used to work out to colors, so I did that. And then ultimately, I just counted by sevens. And as long as I counted, I didn't get anxious. But once I stopped counting, I started feeling a little anxious, so I just started counting again. 7, 14, 21, 28, 35, etc. All right. So I think it's fantastic that they want to do an MRI, because if your pain is always located in a single spot, especially if it's to the left or to the right, your job is to work with your doctor to try to figure out what's at that location, because obviously that's not your bladder, because your bladder's centered. So the odds are it's scar tissue, something else going on there. And so an MRI would really be useful. I would definitely do the MRI. You're not sure though if it's not your IBS. So if your pain is associated with bowel movements, then that points to the bowel. So what's so interesting about having IBS, for those of us who have IBS, is that we really feel stuff. And so with IBS, your large intestine starts on the right side, actually, goes across here, makes a hard 90-degree turn, goes down here, curls around, and ends up at your rectum. Okay? So food travels from here, down here, and over to here. Right? So for those of us who have diarrhea-driven IBS, which is nerve-driven IBS, very sensitive nerves down there, the single most painful section of the bowel is on the lower left side. It's as it gets down to the low left hip bone and moves to the rectum. That's the super most painful part. I call those bend over and screamer cramps. Thankfully, I don't have them anymore, but I had them a lot in my 20s. It was not fun. Didn't realize that there were foods that was triggering it. For me, the foods that give me bend over and screamers are oatmeal and chocolate, which is why you cannot pay me to eat oatmeal or chocolate. Also, for 2 weeks, you're having vaginal itching and it's horrible. The doctor gave me diflucan, took 4 already. What can I do? I have been taking antibiotics, but never this reaction. Well, the proof is in the culture, honey. You don't know what you have. You're guessing. And so they need to do a swab and try to identify if it's candida or not, if it's fungus or not. And if it's fungus, you're going to need to do an antifungal. Make sure you're not eating any sugar, even pasta. One serving of pasta is the equivalent of eating like several Snickers bars. And once that pasta hits your mouth, those carbs are converted into sugar, which immediately feed the candida, can feed the fungus. So reducing carbs is important when you have active fungal infections, candida infections that you're guessing. And so let them do a swab and let's see what they find. If they don't find any fungus, then you could actually be having pudendal neuralgia, that your muscles are now so tight, or whatever's going on your left side is so tight, it's squeezing a nerve, and it's that nerve that's giving you pins and needles, itching, stuff like that. Valeria says, how can I help my mom with IC when we do not have pelvic floor therapy in our country or not professional therapists? Also, the main problem is she's 72. She refuses to look for a therapist abroad. Can she only do some exercises? Can I help her somehow? And greeting from Slovakia. Valeria, thank you so much for coming in. And I hope you're still here, hun, because you asked your question 30 minutes ago. At the age of 72, we're looking at estrogen atrophy. And so let's make sure her skin is healthy first, because the odds are that's what it is. And what I would do is I would buy our book, IC 101. It's not just a bladder disease, it's a Kindle. You should be able to buy it as an ebook everywhere, and it'll only be $9. I would start with that. But again, at her age 72, really, we're looking for estrogen atrophy. Karen said, what's a pumpkin drink you showed last video? Here. So for bladder-friendly teas, you start with chamomile, peppermint. Your next step is rooibos. And this is a pumpkin rooibos tea that we have in our store. I love it. I say it's really good after dinner drink. And it's not pumpkin-y at all. It's not syrupy pumpkin-y like the pumpkin spice lattes and stuff from Starbucks. Very light, very delicate, vanilla-y. It's really quite good. Put a little cream in it, put a little bit of sugar in it, and you're gold. It's like a very, very mild chai tea, but without being irritating at all. And this is by a company called Harney and Sons, right? Yeah, Harney and Sons. And then for the coffee alternative, you want to go with Dandy Blend, which is an herbal coffee that happens to also be quite, it's not bitter, it's wonderful. Dandelion root is the key ingredient here. Dandelion's actually kind of sweet, but this is the chicory, what's in it? Roots of barley, rye, chicory, and dandelion. Man, I could drink this all day. I do drink it all day. I make frappuccinos in the summer. I'll drink 3 of those a day on a hot summer day. Love making frappuccinos with this. Karen says, when are my office hours? In the afternoons, ideally. Just remember, I'm in California, so it's Pacific time. You can call our 800 number, 1-800-928-7496. And if you have a couple of questions, not a problem. If you want to spend a lot of time, go over your whole history, I would ask for you to sign up for a coaching session. But I just know that 95% of the time. We just talk on the phone and it's fine. I'm a terrible businesswoman because I give it all away, right? Which I shouldn't be doing because I got to work on my retirement. But anyway. So if you just have a couple of questions, just call. It's fine. And leave a message. If I don't answer the phone, it's I first come, first serve. I'm known for calling late. So I will call at 5 my time, 8 o'clock Eastern time. So be prepared for late phone calls in return. Judith says, my bladder doesn't like urine. This all started after a Foley catheter. Maybe the catheter irritated a nerve in the bladder. Catheter certainly would have created a lot of irritation in there. No doubt about that, especially if you're older. Jessica says, I was told I have decreased blood supply to my ovaries. I wonder if that affects my IC too. Possibly. You could have pelvic congestion syndrome, which is basically varicose veins in your pelvis, which limit blood supply. There's a specific vein that collects blood, and it gets very, very swollen and very, very heavy, and it limits blood flow to other parts of the pelvis. Jessica says, I had a catheter put in improperly. The nurse put it in upside down. Didn't understand why she would do that. Weird. Karen said, my flare-ups are urethra hurts, like on the outside. I'm 62 and had this problem before I had a hysterectomy too. But Karen, how old were you when this all began for you? Kayleen says, how did I not get the notification? Maybe you've got it blocked. But hey, Kayleen, how are you? Hi, Amy. Hi, Samara. Carol, thank you so much for answering my questions. We'll go in to have them find out. And yes, I will do the MRI. I am phobic, and they have an open one. So thanks so much. Yeah, an open MRI. Way to go. Kayleen said, I had a bladder installation on Thursday. I think he might have scraped between my urethra and my vaginal opening. I called after hours, and he said to sleep on it. And if I'm still in pain, to call on Friday for a UA order. It looks good. Maybe the scratch needs healing. Yeah, it happens. Hey, John, nice to see you. I hope life is treating you well. I really do. Hey, Barbara, nice to see you too on YouTube. Palm says, I had endometriosis causing my bowel to be adhered to my side wall by my left ovary. Absolutely. That's a really good example of left side pain. You know, endometriosis is a beast because you basically get adhesions, and these are not soft pliant adhesions. These are hard, restrictive adhesions that wrap around stuff. I mean, they can wrap around your urethra. They can migrate throughout your body. They've been even found up by the heart, up by the lungs. Endometriosis is terrible. So at least I'm talking better. Yeah, I mean, at least I can talk a little bit more. It's like I'm floating between sore throat, laryngitis. So Renee says, can an endometriosis come back after a hysterectomy? Well, that's a great question. Yes and no. The advantage of having the hysterectomy is you've eliminated the source of the endo. You've eliminated the source of it. But the challenge is that endometriosis starts out very, very small, microscopic. And so there's always the chance that there is small pockets of endometriosis already in your pelvis that if they leave your ovaries in and you continue to have periods, then the endometrial tissue, wherever it is, will bleed. You know, that's why endometriosis is so painful. It's that if it's in your belly, it will bleed when your hormones change, when you have your cycle. And blood does not belong in the belly. Blood in the belly is actually very painful. And so that's why periods are so painful. Lori said, I had the same thing, sore throat and lost my voice. So much better now. Yeah, it was weird. It's like attacked my throat from here to here. I did a COVID test. It's negative. I don't have a fever, but I did have a giant swollen gland right here. And that's better. That's much better. You can see it though. See it right there? Renee had a complete hysterectomy. Well, so having a complete hysterectomy accomplishes a very important goal, and that is because you're no longer going to have those hormone swings, any remaining tissue down, endometrial tissue should basically shrink up and just be done. Samara said, thanks for pronouncing my name correctly. Yay! Renee says, I sound much better since the beginning of the broadcast. Yeah, I've kind of stretched it out a little bit. So, guys, I have a question for you. You know, the book I released that we released 2 years ago, IC 101. It's not just a bladder disease. I had fully intended to do an Audible, so that people could listen to it. Like for me, I listen to books now. I don't read them as much as I listen because I can get stuff done. And by the way, I just finished Prince Harry's book, Spare. You know, when we were kids, we wanted to be a princess and marry Prince. Oh, hell no. Let me tell you, that boy, I feel heartbroken for kids who grew up in the monarchy. It's just very, very difficult. Anyway, so getting back to my question, rather than doing an Audible, did I love the book? It's a heartbreaking book. I mean, it's truly heartbreaking because he was destroyed by his mom's death. You know, he's 12 years old when Princess Diana died. He didn't even get a hug. He did not even get a hug from his father. Can you believe it? Didn't even get a hug. And a lot of his life, and he also completely believed that she wasn't dead. That's how he coped. And William did too, as he calls him, Willie. He believed until his 20s that his mom was so traumatized by her life that they all just thought she'd gone to hide. And it wasn't until he was an adult that he got to see the file of the accident, which allowed him to see that his mother had actually died. But it just, the lack of kindness and care just destroyed him. And so much of his life was just trying to grieve properly. But let me tell you, he is a brilliant orator. He is a brilliant narrator. I would listen to the book. His voice is incredible. The book is incredibly well written. Even though he didn't go to college, let me tell you, he writes like he went to Harvard. But really thoughtful, smart, intelligent, kind, empathic, caring. Makes me proud to be a redhead. I got to tell you, makes me proud to be a redhead. Okay, so anyway, getting back to my IC 101. What I thought I would do instead is that I would just do a video of me reading each chapter. So you could just listen to it that way, because a lot of people listen to these broadcasts afterward, because y'all call me and say, oh, I'll listen to you again. Does that sound like a good do around where I could actually just read the book online? I mean, a lot of people do that anyway. Oh, hail. The next storm, we are in for a big, giant storm right now. And so we have lots of flooding, lots of landslides. I live on a hill, so no flooding here as long as our sump pump works. Valeria says, thanks to IC Network, Jill, and supplements, I could help my mom. Last 10 years improvement, no drugs anymore. Almost any, no pain, day frequency, but night frequency is left. Only this. What can be the cause? So, Valeria, listen, anytime, and it's always worth doing. Anytime somebody's really struggling with nighttime frequency every single night, we buckle right down to what's happening during the day. Because that nighttime frequency literally is driving those nerves to be irritated. And so, is she doing that 1 cup of coffee in the morning? Is she doing green tea, black tea? Even decaf coffee is bad. Something is triggering her nerves badly. Is she taking a multivitamin? Is she taking any other supplements? Is she doing a cranberry supplement, which would be bad? I would buckle down, and it might be something completely innocuous that you guys think is fine, like a piece of candy after dinner, a piece of chocolate after dinner. Renee says, I listened to several of your broadcasts one day last week. I hope that they're helpful. And I know my rule as a support group leader is not to talk about myself, but I have to. Because it's an example of things that happen. But honestly, I need you guys as much as you need me, because my stress level is off the charts caring for my folks. And so I need support just like you guys need support. And this is going to be the year, I think. So I know you'll be there for me, and I need it. So thank you. Cindy says, being on my feet for any length of time causes late afternoon and evening pain. So honey, that does not point to your bladder. That points to your pelvic floor and or pelvic congestion syndrome. We are in this together, Renee. Renee says, please count on us. We need you. We are a team. We are a team together. And again, the gift, if there's a gift in any of this, it's that we will never, ever, ever walk away from somebody who's in pain, because we know what it's like to suffer and be alone. This makes us better people. It makes us better family members, better mothers, better daughters, better sisters, better brothers, better fathers. So Valeria, she's been on a strict diet for years. I still challenge you to look at it. I challenge you to look at it. It could easily be something that she thinks is okay. Like, again, like a vitamin. Does she take any vitamins? It also could be compromised water. Thank you, Carol. Yeah, we are a team. You guys are, listen, I'm no different than you. I think that if I think about my life, right, and I think about where I am today versus where I was in my 20s, I was completely isolated. My friends had walked away. I had 2 friends, and they're still my 2 best friends. All of my friends, from playing tennis, my tennis partners, everybody, they all walked away. And there's this implicit and dominating loneliness that happened, and embarrassment and frustration and dread of, you want to go to a movie, but you have to have an aisle seat. Maybe you need to drive your own car. So if you're uncomfortable, you can leave without bothering anybody else. It's interesting the way we adapt. My first goal in my 30s, when I had severe bladder pain for the first time, but even so in my 20s, my goal was to go to a movie and enjoy it. Because I had one of my worst stories of my life, going with my ex, going and seeing a Harrison Ford movie. And I made the mistake of drinking a fountain 7-Up. I was literally screaming inside in agony from that. And it kind of, created this fear of going to the movies. So I was out on disability, right? And I still thought I was dying of cancer. I didn't really understand the injury back then. But I would go to a matinee by myself. And I came to treasure that moment. I came to treasure those moments. I did. Because number one, I could get up whenever I needed to. But I was able to prove to myself that I could do it. I was able to prove to myself that I could leave the house and go do something enjoyable, even with IC. But there is stress trying to go with somebody else because, it's just stressful. You have to figure out who's going to drive, then you don't want to inconvenience them, and then you have to figure out where you want to sit. And it's always going to be on an aisle, and it's always going to be near the back so that you can dart out quickly to go to the bathroom, right? Same is true with flying. Now, listen, I've flown to Europe a couple of times with this. I brought my microwavable heating pad when I flew to England because I was there to speak about IC on the BBC. So they flew me back, and I got to fly first class. I would only fly first class, literally, back then, because I was in so much pain. It's like, you're going to make this really nice for me. And they did. And I brought my microwavable heating pad, and I handed it to the flight attendant. Can you heat this up for me? She goes, Jill, we don't have a microwave. Like, oh, okay, this is not good. So I was slapping my thigh. This is an old technique that's based that started in India with leprosy. Leprosy is a bacterial disease that eats away at your nerves, right? And so people with leprosy literally they can't feel the nerves are destroyed. So they're walking on bone. They have no idea they have these big wounds. So there was this guy who wrote a book that I read early, Pain, the Gift, that something. Anyway, he walked up to a leprosy clinic where that was where the forefront of pain management was. And the lepers were doing this, right? And this is actually a really compelling way to reduce your pain, because we have thousands and thousands of pain receptors in our body, right? And if they were all firing at once, our brain wouldn't know what to do. So we have something called the gate. We have the spinal gate. Only the most important pain message is sent through to the brain. So this is a way of distraction. So if you're driving in a car and you're starting to have a flare and you don't have meds, do this. And, you can make it sting a little bit. You can make it sting a little bit if you want. Don't beat yourself up. But what happens is this gets your brain to pay attention to another more urgent source of pain. So it stops letting the bladder pain message through, and it brings this pain message through. And this is the foundation for what became a TENS unit, where a TENS unit does the same thing electronically. So I was flying to Europe. We were over Greenland, and I started slapping my leg because it hurt so bad, right? And and that was breakthrough pain through pain meds. And so they brought me, they were sweet, really hot towels put in a baggie, wrapped in a towel. And I slapped this massive heating pad on my belly, and I got through it. Don't you wish we had Star Trek transporters? Can we just step into something and arrive in Scotland? Please, God. Valeria says, thank you. From Desert Harvest multivitamins, and she drinks only spring water. I would stop the multivitamin, hon. I would stop all multivitamins, even our low acid vitamins, whether it's Desert Harvest or odd, there are going to be some patients who are sensitive to even the low acid vitamins. So I would back off on the multivitamin for several weeks to see if that makes a difference. I would. It is exactly the same thing as TENS. Renee says, I use my TENS. I love the distraction slapping. And that was all from lepers in India back in the early 1900s. Fascinating, right? You know, there's another book. Where is it? Where is it? Oh, it's this fabulous book that we sell. Oh, here it is. Okay. Now listen, if you're struggling with pain, you know, knowledge is power, my friends. Knowledge is power. It's not just, hey, you know, I'm just going to go ask for pain meds. You got to understand the pain mechanism a little bit more. This book, When It Hurts Down There, is simple, it's easy, it explains everything, and it gives you really easy, good tips to deal with a quick flare. Samara said, what vitamins are bad? B6 and vitamin C in the form of ascorbic acid. Katie, thank you, hun. Thank you. If I disappear for a couple of weeks, and you know that I've lost one, and I'm going to try not to do that because I know I can be really honest with you guys. And if I'm sobbing my eyes out, you'll be here for me too. So, okay. So anyway, here, this is what, I mean, this book is just fantastic. It's just so easy. It's so simple. An introduction to pain processing, right? So it talks about the gateway. It talks about context. It talks about final processing. Body pain signals come in different flavors, organ pain and non-organ pain. Pain can be coming from your organs like your bowel, your heart, or your bladder, or it can come from your skin, your muscle, or your joints. These are two types of pain that feel really different to you. Pain signals from your organs are more likely to be coming from stretch, the lack of blood flow, or inflammation. When you eat too much at Thanksgiving, your stomach sends a stretch pain signal to the spinal cord. It makes you feel achy, uncomfortable, and nauseated. Organ pain is hard to describe, but it is like a tightness or a squeezing fullness. It is hard to sit still. Acute organ pain can also be accompanied by a set of symptoms like being pale, sweaty, feeling a sense of impending doom. Chronic organ pain, on the other hand, tends to be more dull, a dull ache or discomfort that doesn't go away. It ebbs and flows, gets worse and better. And when they are bad, you can have nausea, sweating. When the pains are not so bad, you'll notice just general discomfort. Skin, muscle, and joint nerves are more sensitive to cutting, burning, and crushing. Well, anyway, it's just filled with useful tips. I mean, it's amazing. It's so good. So anyway, here's the thing that I love about this book. Okay, so technique number 1, avoiding the foods which cause inflammation. Okay, like gluten, refined carbs, fried food, processed meat. Anyway, avoiding common irritants like the bladder foods. Reducing your intake of oxalates. We certainly know that oxalates can be irritating. There's also foods associated with endometriosis. I really didn't understand that before. With a high fat content increases estrogen and endometrial growth. Adding and supporting good bacteria to your gut. Avoiding unnecessary antibiotics. Please, thank you very much. No antibiotics when you're flaring, for God's sake. Start exercising, which I need to do today, but it's raining. And then This is really important too. So I know for me, especially after I was diagnosed with IC, I had a very specific thing that used to happen to me. I would have vulvar pain for hold on. I would have vulvar pain for a day, then I would have vaginal pain for a day, and then finally I would have bladder pain. There was and it's like every single flare, that's the way it was. It's like, why did that happen? Well, number one, for me, now we know that was tight muscles just squeezing everything. But this is something that she points out. And this is important that you all understand, is that all the nerves in the pelvis merge at the spinal cord. We have something called neurocrosstalk. So we had a research study which showed that if you irritate the bowel, the bladder will show the exact same irritation. If you irritate the bladder, the bowel will show that exact same irritation. Why? Why does that happen? It's because they're basically the same nerves up at the spinal cord. They've done radioactive tracer of nerves in the bladder, different radioactive tracer of nerves in the bowel, and they follow them. And guess what? They merge into the same nerve of the spinal cord. So neurocrosstalk. And that's an important theme in the IC world. And that's why if you have an injury in one place, slowly but surely other nerves also become involved and become inflamed because of neurocrosstalk right here. So that's cool. But I think, anyway, it's just such a good book. Alleviating pain by targeting brain processing. Technique number one, use foul language when pain starts. In other words, if you've ever hit your thumb with a hammer or stubbed your toe on a table, you probably sworn or at least wanted to. This kind of reactive vocalization starts in the lower brain. It's a spontaneous reaction to pain, and it actually reduces the pain signal. Now, I'm not suggesting picking up a general expletive habit. This only works well when you're not accustomed to using foul language regularly. And if it's against your morals to use foul language, then you can skip this technique completely. But if there is ever a time for you to swear, it's now. When you have a flare, it's okay. I do. She talks about deep breathing, meditation, all sorts of other stuff like that. Just please, this little book could change your life. It's so good. It will really help you understand not only why the pain is happening, but the different ways you can challenge the pain, the different ways you can reduce the pain. Okay. It's in the IC Network shop, and I don't remember how much it is. How much is it? It's worth every penny. Zan says, let's give some likes on this live. Thank you, Zan. Thank you. Yeah, you guys, go ahead and like this stream. I appreciate it. Renee said, guilty. Barbara said, what's the best prep for a person with IC? And as I said earlier, Barbara, this is the time. Lots of people are getting colonoscopies right now. The Miralax prep, I think, is the best prep. But we have a new prep that doesn't involve drinking at all. It's just pills. You just swallow a bunch of pills. So I think that would be the best prep of all, where you don't have to drink a lot of Go Lightly or Gatorade with Miralax. I would definitely prefer to do that myself. The next time I have one, I will probably do that. But we just really, we don't have a lot of reports of patients flaring with colonoscopies. I think, honestly, when we think about how the brain processes pain, literally, brain is going to be focused entirely on your bowel. It's not going to pay attention to your bladder at all when you're doing the colon prep. It's not. That's the gate. That's the spinal gate. So I don't think, maybe one patient in 20 years has called to say that they've flared with a prep. I did not flare with the Miralax protocol. I did not. The only thing I would just say, so Miralax protocol is 4 biscotals at 5 o'clock the day before. And then it's a bottle of Miralax divided into 2 liquids. You can do water. You can do pear juice. I did Gatorade back then. And the only thing that I would say, if you do the Miralax protocol, it gets kind of syrupy thick. So it gets a little hard to swallow. And so I think you can get the first one down, no problem. Piece of cake. It's getting the second one down. And especially getting the last, cup of it down. You're just gagging. It's like, please, I don't want to do anything else. Get 2 flavors. You want 2 separate flavors. So when you start that second bottle, you get to focus on something new, and then you won't have that cloying flavor, right? That cloying flavor that's happening. Gay says, prayers for you as you take care of your parents. Thank you. I've never been under this level of stress. I mean, I'm feeling it. Getting back to Valeria, I've definitely worked with patients who cannot take any multivitamins, even the low acid. Low acid vitamins, this is an interesting story, were actually my idea. I was on the phone talking to the CEO of Far Laboratories about 15 years ago. Really nice guy back then. He's gone now. His name was Al Rodriguez. We were just, shooting the whatever, talking about supplements. And he goes, Jill, if you could make anything for an IC patient, what would you make? I said, I know exactly what I'd make. I'd make a multivitamin, like that popped out of my mouth. I think I would make a low acid multivitamin. And he said, why? And I said, because I get that question every day. Is there a bladder friendly multivitamin? And there wasn't back then. And we moved on and started talking about something else. And I just thought, he just kind of blew it off. Well, but 6 weeks later, he called me and he said, I've got your low acid vitamin. So our first low acid vitamin was Multi-Right. And you can still get Multi-Right from Far Labs over on their website. We sold that for many years. And I took it. Patients did great with Multi-Right. The problem was it was a horse pill. And it was dry. It was too big, and it was hard to swallow. It was getting stuck in people's throats. And so, I asked Natural Approach Nutrition if they would make us a new low acid vitamin that was different, a few less minerals, so it wouldn't be quite as big and easier to swallow. And they made Bladder Smart, and that's the low acid vitamin that I take. And it has a new label. Let me go get it. Hold on. Do I have the... So Bladder Smart was the second low acid multivitamin on the market, and then Desert Harvest decided to create their multivitamin, low acid multivitamin now. So there are 3 on the market. But Bladder Smart is the one that we sell because I asked the company to make it for us. It's been quite good. Sally said, is it possible for Hunter's lesions to heal on their own over time? The answer is yes. And hold on. Hold your horses here. Where is it? Okay, so hold on. This is exciting. And I think I have it open on this computer. Hold on. So remember that there are 2 theories about Hunter's lesions. Okay, theory number 1 is that it's a viral infection. because we have research that shows that some patients with Hunner's lesions do actually have viral infections in their bladder. Theory number 2 is that it is nerve inflammation, that it is a nerve that is being massively compromised in some way. So a year and a half ago, a remarkable case study was published of a woman with severe Hunner's lesions and a severe prolapse, okay? And when they went in, and her prolapse was so bad, she couldn't pee, so they had to try to surgically repair that. That was their priority. So when they opened her up to repair the prolapse, they made a remarkable discovery that a ligament was broken. And her uterus, your uterus is normally held on both sides by ligaments. One of hers was broken. So the back of her uterus was facing front, and the front of her uterus was facing backwards. So they repaired that. And something miraculous happened. Her lesions healed completely. And this week, it turns out that this, and I wanted to find this article, there are more and more reports of this happening, that there's a specific ligament that if it's damaged, and I swear I just had it open because I was looking at it yesterday or the day before. Let me see if I can find it. Hold on. Yeah, here it is. Here it is. Okay, this is very, very interesting. So this is a letter to the editor in the International Neurourology Journal last year. And the title is, and this is by a guy from Australia, interstitial cystitis, a consequence of weakened uteral sacral ligaments failing to support visceral plexus and bladder stretch receptors, and therefore potentially curable. So this is a letter to the editor, and this guy, let me just, I want to read a couple of paragraphs of this, okay? So this is really important because, again, remember, we don't think of IC as an incurable bladder disease anymore. We think of it as a neuromuscular disorder. And in this case, basically, if this ligament is damaged, it causes kind of a cascade of reactions to occur, including activating nerves, which could potentially cause lesions. So let me just read a couple of let me just read this to you, okay? I read the State of Review of IC Bladder Pain Syndrome by Ueda, this is a doctor from Japan, with great interest. An erudite scholarly paper, it states that there is a crisis as regards to IC, namely that there's been no progress for 25 years. The authors concluded, thus, there can be no bright future for IC without these 3 steps. We must understand the symptoms. We must detect abnormal findings in or outside of the bladder, and we must verify that the abnormality is the cause of the symptoms. This commentary aims to address her statements first by introducing an important discovery to the International Neurourology Journals, Dr. Shuffler's histologically validated cure of IC with Hunner's ulcer, and then by discussing its implications relevant to these 3 statements. Shuffler set out to manage a 73-year-old woman with classical posterior fornix syndrome. This is the patient I was describing, where her uterus was backwards. Predictably co-occurring with chronic pelvic pain, urge, abnormal emptying, nocturia, and frequency caused by the laxity of the uteral sacral ligaments and was cured by repairing thereof. Not IC, but by repairing the cardinal ligaments and US cells, which is a standard cure for posterior fornix syndrome. To test whether any relationship exists between posterior fornix syndrome and IC, we revisited previous data of 46 women with chronic pelvic pain and 171 with bladder symptoms treated for posterior fornix syndrome with tissue fixation with a sling surgery. Their workup, okay, I don't need to do that. The cure rates were 76% for chronic pelvic pain, 74% for urgent incontinence, 80% for abnormal emptying retention, 75% for nocturia, and 50% for frequency. In another study, among 1,420 women with a prolapse and posterior fornix syndromes were treated by 2 different sling operations. 1,179 had bladder symptoms, 599 had chronic pelvic pain, and 162 had fecal incontinence. Anyway. So how is it, let's see, hold on. So how is it that posterior fornix studies following the integral theory paradigm have reported pain and urge cure by repairing the ligament, while scholarly reviews have stated that the pathogenesis of IC is unknown and there's no cure? The answer may be found in Thomas Kuhn's famous book. You guys, I know I'm geeking out here, but let me just get through this. The answer may be found in Thomas Kuhn's famous book, The Structure of Scientific Revolutions. Kuhn states that the solution to chronic problems in science do not arrive gradually. Instead, they arrive in leaps. They are usually disruptive and become normal science when there is a crisis. The leap in science behind the IC cure was the integral theory of female urinary incontinence. Anyway, so let's see. In conclusion, if a non-Hunter's IC is proven to be the same or similar to posterior fornix syndrome, it answers the dilemma of Ueda, collectively assuming that Hunter's lesion disease and non-Hunter IC is one disease entity has become an impediment. It also opens the door to future research to to further investigate the hypothesis presented here for the cascade of pain and end organ inflammatory reactions caused by the inability of loose ligaments to support the visceral nerves at T11 through L12 and S2 through 4. Okay. What does that mean? As Dr. Weiss says in his book, Breaking Through Chronic Pelvic Pain, Western medicine fails the pelvic pain patient. Why? Because doctors play in their sandbox. Urologists focus on the urinary tract. Gynecologists focus on the reproductive tract. Gastroenterologists focus on the bowel. They don't look at relationships. And the problem with the pelvis, the problem with this area is it's a very small confined place with a lot of stuff happening. And nothing operates in isolation. Everything influences everything else. We know that an organ like your bladder can change the way your muscles behave, because if you have a UTI or you're going through chemotherapy, your bladder is going to be screaming for pain and your muscles are going to get tight to protect you, right? It's called the guarding reflex. It's called the viscerosomatic reflex. The far more important question is, can these muscles change the way the bladder behaves? And the answer is absolutely, because if these muscles are tight, they restrict blood flow to the bladder and the bladder is going to break down. If your bladder doesn't have good oxygenation and good nutrition, your bladder is going to suffer, right? But what they're doing now is they're going beyond the muscles and they're looking at the totality of the pelvis, specifically things that are out of position. So if you have a prolapse, if you have a uterus that's tilted forward, tilted backward, tilted to the side, whatever, just as muscles can change organ behavior, so can broken ligaments. There's a whole cascade. There's a whole ripple effect that in the end will cause nerves to become inflamed. And we know that when nerves become inflamed, they release substance P. What does that do? That damages tissue, aka a Hunter's lesion. So if we can get everything back into its proper position and reduce any stress on the ligaments and on the nerves and on the muscles, will that heal a Hunter's lesion? Yes, for some of you, it could. So posterior fornix syndrome, it's a fancy way of saying that a ligament is broken. Let me see if I can draw you a picture real quick, because this is really interesting anatomy. Hold on. Give me a piece of paper. I need a piece of paper. All right. All right. So where your uterus meets your vagina is the cervix, right? Most of us think that it's a wall, right? Uterus, vagina, right? So most of us think. Here, hold on a sec. I gotta open up this window here. Most of us think that the cervix is basically just kind of a wall, just an opening. But it's not that way. Actually, the cervix is kind of like a pucker, right? So let me see if I can draw this. So here's your vagina. Yeah, I can draw this. And then here's the uterus. And here. Okay. Think about puckering your lips, right? So here's your uterus. Here's your vagina. And the cervix is like a little pucker that pooches out into the top of the vagina. But there are pockets. There's a pocket here, and there's a pocket here. And they're called a fornix. And so the way it's very easy to diagnose if you have posterior fornix syndrome, because if one of these is sagging, what they'll do is they'll just put a wooden speculum right here and they'll lift it up. And if by lifting it up, it makes your symptoms go away, it's a de facto diagnosis of posterior fornix syndrome. So that was something new I hadn't really thought about before, is what does this, I mean, I don't have a cervix anymore, so I begged to keep my cervix. They said, no, you might have cancer. So I lost my cervix, but it's very, very interesting. The anatomy of it's very, very interesting. Carol on YouTube says, how long will it take for a vaginal estrogen to calm a urethral flare? It took about 2 weeks for me. I stopped it when I started oral hormone therapy, thinking I didn't need both, but started a horrible flare. I think I'm going back. Yeah, or the oral therapy is never going to be as effective as topical, because you're not going to get enough estrogen to the tissue. Topical hormone therapy delivers 100% of the estrogen exactly where you need it. If you swallow it, it goes throughout your body. That's why oral or systemic therapy carries a risk of cancer, because it's spread everywhere. Whereas if you just put it in a lotion on your skin down there, it stays there. So yeah, that was, and I thought the same thing too, actually, early on. I didn't understand that. Elke says, just got 10 days of amoxicillin and Steftin 2 times a day. Culture showed few bacteria, but large leukocytes. Well, then the dipstick showed leukocytes. Did they do a culture? Elke, did they identify a bacteria? Because now you're going to be on 10 days of an antibiotic that's going to mess up your biome potentially. Sally says, how would they diagnose posterior fornix syndrome? They just use a little wooden speculum, and they just put it in the little pockets that are kind of around the cervical opening. It's not awful at all. Very, very easy to do. It's a very, very quick diagnosis. So they just put the, well, yeah. Okay. So here, okay. Here's a fornix. Here's your cervix. And then there's another fornix up here, right? So if this one is kind of collapsed, they're just going to stick a wooden speculum right here and tilt it up. And if they tilt it up and it makes your symptoms go away, you are gold. You are gold. And that means that you have a broken ligament or a stretch out ligament or a damaged ligament. Elke says you had 80,000 E. coli and 10,000 Enterococcus facilis. Okay. So Elke, hopefully when they did your urine culture, they did something called antibiotic sensitivity testing. With antibiotic sensitivity testing, what that does is that identifies the antibiotic that the E. coli is drug resistant to versus the antibiotics that will kill it. One of my senior project in college was the identification of drug-resistant bacteria and their genes. And so I have a lot of personal experience doing this. So the reason it's the second half of getting your urine tested correctly, because we don't want you to waste time on an antibiotic that won't kill it and allow that infection to grow. Amoxicillin is viable. The stronger form of amoxicillin, Augmentin, is pretty well known for causing bladder flares. Amoxicillin to a lesser extent. You'll have to see how you do. If you feel like you're flaring from it, you might need to call the doctor and say, is there another antibiotic that I can do that will not irritate my bladder so much, like a cephalosporin, like Keflex? But it's all, the proof is in the antibiotic sensitivity testing. A lot of people call and say, what's the best antibiotic? There's no answer for that. There's no answer for that. There's no such thing as the best antibiotic. It's what is your E. coli vulnerable to? And the problem is the antibiotic resistance has skyrocketed. And there's y'all remember the Costco chicken debacle? The people who got very, very ill with eating chicken. And that was because they massively overused antibiotics at one of the poultry farms that Costco bought from. It wasn't found anywhere else. It was only found in Costco chicken. And it was actually named specific. I don't remember the exact name, but that variant was named after Costco or whatever, Foster Farms or whatever. Costco bought their chickens from Foster Farms, and it was Foster Farms that had this problem. And amazingly, they never even issued a warning because they just, the instructions say to cook it. If you cook it properly, supposedly the E. coli died. But drug resistance is random. Drug resistance is challenging. And, there's this perception that we get infections because of poor hygiene, that we're not wiping from front to back, we're wiping from back to front, which would wipe poop up towards your urethra. Well, that's a load of crap. Actually, probably most bladder infections are coming from food now. They're coming from food, specifically meat products. There was a very rare drug-resistant bladder infection that hit colleges in Washington, Idaho, and Oregon. And there was a big group of students who got this really rare, unusual bladder infection, and it was isolated from a slaughterhouse that sold meat to universities. And they traced it back to a farm that massively overused antibiotics. And the big challenge now with E. coli is that, you just can't guess anymore. You really have to demand antibiotic sensitivity test, or better yet, next generation DNA urine test, because that will tell us immediately if there are any drug resistant genes in your body already, right? I'm resistant. Every time I have next-gen tests, I always find aminoglycoside resistances, and that's a medication which I don't believe I've ever taken. And remember, I've got a degree in pharmacology, drug development. Believe me, I pay attention to every single thing I put in my mouth. I have never taken an aminoglycoside. And yes, I have this very strong aminoglycoside resistance. And the only way I could have gotten that is if somebody gave it to me when I was in surgery, when I was a kid, or I got it from food. Oh, Barbara. Barbara says, thank you so much, honey. By the way, I forgot to tell you about now last week in our meeting, we talked about a new study which found that Manuka honey showed some benefit in calming bladder inflammation down. This is not the first time I've actually written about honey in years past. I have a blog on our website. We had researchers, I think, in Detroit who were studying using honey in bladder installations. Honey is known for its natural antibacterial, antifungal properties. And now we have yet another study which is finding benefit with Manuka honey. And that's what I've been doing all week for this weird sore throat laryngitis thing I got going on. And it's been wonderful. So when you're looking at sweeteners, if you can afford it, get Manuka honey. It's just honey, but it's honey from New Zealand. It tends to be more expensive. But Google it, Manuka honey health benefits. It's got a lot of health benefits. And of course, back in the old days, 1,000 years ago, they used to put honey on wounds anyway. So Kristen, Cologuard might be another option for patient, no prep at all, not as accurate as colonoscopy, but better than not doing anything at all. Exactly. Renee said, were these issues before or after the prolapse surgery? Before. She had the Hunner's lesions before the prolapse surgery. And after the prolapse surgery, when they repaired the ligament, her Hunner's lesions completely disappeared. She's considered a total cure. Samara says, I do ECT. What does ECT stand for? What does ECT stand for? The initials are not registering in my brain. Of course, I can Google it. Let's see. ECT. Oh, electroconvulsive therapy. Ooh, interesting. I mean, yeah, I think that's a good idea. Where do I have it? I have got, in my giant pile of books to read, I've got a couple of books on how to heal brain chemistry. Because I'm looking at it from the perspective of childhood trauma. That childhood trauma rewires our brains. I know my brain is rewired. And childhood trauma can leave the brain in a state of hypervigilance, anxiety, the sympathetic nervous system dominating brain function, feeling like your life is at stake, 24 hours a day, 7 days a week. And so this is something that I've been processing and learning a lot about as I try to understand my life a little bit more. And one of the ways to try to re-regulate the brain is to do electroconvulsive therapy. And power to you. And, in Prince Harry's book, he did in a medical setting because, again, he was dealing with, Prince Harry had terrible anxiety disorder. Terrible. He was having panic attacks all over the place. I mean, he's just like us, guys. For those of us, IC subtype 5, central sensitization, um, and again, trauma driven, just this whole kind of central nervous system cascade. So he did, with the help of a doctor, hallucinogenics. And he said it was very helpful for him, but you only do it in a medical setting. But he said it kind of opened up. He couldn't remember, after his mom died, he couldn't remember experiences with her. It was like he completely shut down. I mean, he remembered that his mother, but he couldn't remember when they laughed. He couldn't remember events. He just couldn't remember them. And with the therapy that he did, they were able to open it up. And he now can remember all of that now. So he can remember the good memories instead of the bad memories. I'm telling you, his book is fabulous. For anybody who's had childhood trauma, I really recommend it. It's very validating, very comforting, very, here's a guy who has it all, you think has it all. You would never guess that he stayed home alone for years. And that for him, it's the trauma of hearing a camera. It set off anxiety because that's what he grew up with, the paparazzi. And his story is really meaningful and very comforting and very affirming. Also, I gotta say, listen, if you have Netflix, if you can watch the Oprah Prince Harry trauma documentary, that also is very affirming and fascinating. And they really talk about this and Prince Harry does this, as an injury to the nervous system. They're not talking a disease. It's not a disease, it's trauma. What happens to the central nervous system during periods of extended trauma. And again, just very, very affirming. I really recommend it highly. He is doing great now. He's done a lot of therapy. It's making me think I should go back to therapy myself, just to kind of process the stuff I'm going through right now, right? Denise says, hi, Jill, keeping you posted on my colonoscopy and endoscopy prep. You took the 24 pills, not as bad as the drink, but I did get nausea on the second round of pills at 1:30. You felt pretty sick. But all in all, the best part was all the 16 ounce of water. My bladder did great. My colon was great, but I do have gastritis and acid reflux. And he saw some bleeding. He wants me on Prilosec, but I think the prep totally messed up my gastritis. It's worse than ever. Hopefully, yeah, my gastritis got not. Remember at our last meeting, I said I tweaked my jaw and went and took a very strong Advil. I'm telling you, whoo, did that pick up my gastritis all week. That's been going on too. It's getting better now, but Sally said, yes, let's all go to therapy. I'm not against that, because I think that we all have individual experiences, individual histories. Nobody's saying IC's all in your head at all. IC's real. It's treatable. Muscles are treatable. Nerves are treatable, but it's hard to do it alone. It'd be really nice to have somebody to just talk with. Therapy isn't about somebody telling you that you're messed up. Therapy is about somebody helping you understand what you might be struggling with and helping you find a good approach to it. It's about skills. Elke says soldiers with PTSD have said that ecstasy has healed his amygdala. I can see that, but again, we can't. We have to do it in a correct medical setting. We don't want to damage the brain anymore. You know, when I was a kid, the boy that lived across the street, his name was Craig, was brilliant. Just he was a mathematician. He was just kind of like my brother. My brother got a perfect score on the math part of the SAT. So did Craig. But when I was growing up in the 60s and the 70s, there was a lot of heavy drug use, and he took something that destroyed his brain. And he went from being the superstar to being violent, aggressive, and not able to put a sentence together with one overdose of some, never knew what it was. And I never did recreational drugs because of what happened with him, because I saw it happen. And I don't know what happened to him. His sister was taking care of him, but he was kind of homeless, kind of, this brilliant genius young man, just destroyed by something. And that's the thing we all have to understand. We got to remind the kids in our lives, especially now, is that the drugs are coming from Mexico and China. And believe me, they could care less about your health. They put all sorts of crap in that. And you should never, ever, ever trust somebody selling you pills. You shouldn't. It might be nothing. It might be fatal. There might be fentanyl in it, I mean, how many people have died of fentanyl overdose? They're just cutting fentanyl in right and left to everything because fentanyl increases addiction. They don't care if you die. They don't care if you take one pill and die. They're just trying to make money. So please remind your children and the teens in your lives, and everybody in your lives, that they don't care about you at all. They could care less if you die. They just want your money. Therefore, don't trust them and don't take something you bought on the street. Period. End of story. Right? Yet there are police officers who, just by searching somebody's body, who have gotten fentanyl on their hands and it's knocked them out. And so we got to be smart here. But Elke, I like that. I completely believe that. I think there's so much we don't know about brain chemistry that we need to know, and we don't even have the biggest brains on the planet. We think we're all smart. No, whales are a hell of a lot smarter than we are. Although people could argue that, I guess. All right. Well, guys, let's end. We've done pretty good considering the voice. So, how long have we been going? We're going 2.5 hours. So let's, any more questions? If there are no more questions, I think what I might do is I might read, look at that, Amazon chart just pulled up. I might go ahead and use this as a time to read maybe the first chapter or two of IC 101. Amy says, I have a urodynamic study scheduled for the end of the month and I'm still in a flare for 2 months. I heard these can make IC worse. Should I cancel the appointment? This is the second urologist I see treating overactive bladder and not my IC urologist. Well, urodynamics, I mean, I had urodynamics done. All urodynamics will do is test your nerves. Are they functioning normally? So basically with the urodynamics, you're on a table. They put an instrument in your bladder and a specific measurement tool. It's kind of like a cystoscope, or it might be a cystoscope with different. I've never done it obviously, but anyway, they put something like a cystoscope in your bladder, and then they slowly fill your bladder with fluid, and they're going to ask you, when do you first feel the need to pee? And that gives them something called, well, let's see, waking bladder capacity. But no. I mean, that it's testing your nerves while you're awake, right? So they're going to ask you, when do you first feel the need to urinate? You're like, okay, I need to pee. Then the next one is, okay, tell us when you first feel discomfort. And then you're going to go, I feel discomfort. You can stop now. And then what mine did is they said, well, just hold tight. We're just going to put a little bit more in. And you're like going, oh, please stop. I'm done. It hurts. Right. They will put just a little bit more in there. And that's testing something called your awake bladder capacity. And that is how much urine can you actually hold in your bladder when you're awake versus when you're asleep, when your nerves are all on. And so, I mean, it's a valuable tool, but it's not recommended for interstitial cystitis at all. It can help define or affirm a diagnosis of overactive bladder, which basically means your nerves are not behaving normally. But Amy, are you having a pain flare or just a frequency urgency flare? Because you say you've been in a flare for 2 months. What are your symptoms with your flare? Samara says, I love therapy and learning about the brain and neuroplasticity. I love your attitude. I love that approach. I think that, we're learning so much about how the brain adapts with time, how the brain heals, how some nerves are damaged, other nerves slowly go in and take over. Neuroplasticity is a very, very important concept here, that nerves do heal. The brain can heal in its own time, in its own place. Okay, so Amy, are you having a painful flare or just a frequency urgency flare? I guess I don't understand why they want to do a urodynamic. And why did they say they want to do it? I don't quite understand. Elke said, with a doctor, of course, like Cary Grant had PTSD? Really? I love Cary Grant. I didn't know that. Peeing up to 40 times a day and you're in pain. Well, so Amy, you are an anatomical mystery to be solved here. We've got to figure out what in your pelvis is driving your symptoms. And again, as I've said before, we no longer think of IC as a bladder disease. We think of it as a neuromuscular pain disorder. And for the vast majority of it, our bladder is being victimized by something else. You cath every night with bupivacaine. And did you have lesions? And you know what, guys? Quick potty break. I'll be right back. Amy, can you answer? What did they find when they looked in your bladder? I just have to go pee pee quickly. I'll be back. All righty then. They haven't looked in 2 years. Well, I'm telling you, let's see. Urologist is treating me for overactive bladder with Miratrick. Gynecologist said my pelvic floor is normal. You don't know. They haven't looked in 2 years. Boy, I tell you, if it, then the urodynamics would be a great opportunity for them to also look in your bladder and just see what the hell's going on. So I would support that. I would support that. I think you just have to be really clear. I want you to look in my bladder. Because the thing is when you numb the nerves, you feel better. So that implies that there's a problem with your bladder wall that's exposing those nerves. And so I again, I don't like guessing. I like facts. And at least for me, if I'm in pain, I want somebody to look at it and tell me why I'm in pain. And your symptoms are really extreme, hon. If you're peeing 40 times a day and you're in pain, your symptoms are definitely in the more severe. I would want somebody to look. So I would support having that urodynamics if it would also allow them to just take a quick look at your bladder. Because if you have a normal bladder, then we're gonna have to focus on the health on your nervous system. That your nervous system is messed up in some way. The other thing I would want to know too is there any chance you have a fibroid tumor in your uterus that's pushing on your bladder? And also too, let me just ask you this, Amy, this is interesting. Are your symptoms positional? Is it worse when you lay down to go to bed? Is it better when you stand up? Did I find the photos of the bladder? You know what? Hold on. I can do that. Hold on. Hold on. Let me do this. Let me open up this. Cancel. Hold on. Yeah, I can print. Oh, wait a second. Oh, no. Okay, hold on. Let's try to remember if I printed something out or not. Did I already print it out? No. Okay, here, hold on. I took screenshots. So let me grab these screenshots. Yeah. Here they are. So hold on a sec. Let's start with this one. Ooh, yeah, I got some good pictures for you. Okay, file print. All right. There's one. Okay. These are interesting pictures, so you'll like these. Hold on a sec. Okay. Okay, there's another one coming. Okay, I'll delete that one. Okay, I already printed out that one. This is from an atlas. So, one of our big challenges is, do doctors know how to identify a Hunner's lesion? Do they know what they look like? And so some researchers published an atlas 2 years ago, and I was actually going through it for somebody who sent me a picture of their bladder. All right. All right, here we go. Wonder if I can make that bigger. Let me see. Oh, yeah. Oh, here we go. Here we go. This'll work. This'll work. Okay. This is the one. And and then we also have a picture. Okay. Okay. So I think there's one more. Figure one. Okay, hold on. Okay, hold on. I got another one here too. I'm just trying to zoom it in. Okay, here we go. Okay, this is cool. Okay, so these are new pictures of Hunter's lesions. So these are called classic lesions. They have what you call a coagulum. They have a center, which you can see right here, which is basically kind of a emergence of blood vessels, right? Classic Hunter's lesions with coagulum. They have a stellate appearance with neovascularity of the central coagulum. Okay, so the top three of these are the easy ones to identify. I mean, if they see a red spot with kind of stuff around it, that's suggestive of a Hunter's lesion. Now, these are more Hunter's lesions, but they don't have that central red spot. But they have what we call a stellate appearance, that there's a center and then kind of arms radiating. And one of the things that we see is a lot more blood vessels. This is called angiogenesis. Angiogenesis is the growth of more blood vessels. So we see very clearly more blood vessels happening here, right? And then in this picture, let's see. These are Hunter's lesions that are very inflamed. So we see a lot of extra redness. It's obvious that the tissue is very, very angry. And then these are lesions that have healed. There's no inflammation. You basically just see the white spots. So these are lesions which are not particularly active. So one of your questions was, do lesions go away? Yes, they can go away. They spontaneously disappear. It's about understanding cause. Think about inflammation for a moment. Inflammation is, your body's warfare. It's your body trying to protect yourself. That inflammatory process is your body's warriors going to work in the area to try to fix whatever's wrong. And when you biopsy lesions, there's massive inflammation that the rest of us do not have. That's why we distinguish Hunter's lesions as its own unique group. You biopsy my lesions, I do not have, my bladder, there's no inflammatory markers in there. You biopsy a Hunter's lesion, there's massive inflammation going on in a lesion. Massive warfare. So again, our challenge here is to try to figure out why. And it was the Europeans who just found viral infection in some. Now, I was talking with one of the top doctors in Europe a couple weeks ago, and the European guidelines for IC very clearly say you should check for viral infection. And so I asked him, I said, well, are you checking? And if you're finding virus, are you treating it? And his answer was, well, we don't look for it because we don't know how to treat it, so why bother? That was a little disappointing. I mean, obviously, that's going to be something that our own National Institutes of Health has to do, because, the Europeans came out 7 years ago or so with their viral findings, and the Americans confirmed it. Our MAP Research Network has urine samples from hundreds and hundreds of patients. And so they went back and they looked for virus, and they found virus in about 5% of patients. So, and we know COVID cystitis can be COVID virus living in the bladder. I mean, that's really only in the patients who have the most severe COVID. For the rest of us, it's usually an inflammatory reaction rather than an actual viral infection, or it's the cytokine storm. So anyway, I said, what are you doing about it? He goes, well, we don't look for it because we don't know how to treat it. And I'm just like, oh. I did say this. So I was working with a patient with long COVID who was what we call de novo cystitis. She didn't have cystitis before she got COVID, so she's obviously a COVID cystitis patient. And I did suggest lysine, because we use lysine for herpes infections. If you get cold sores, which is herpes virus, we've got lysine-based chapsticks you can use. I've used them myself, that really cut the infection short, because lysine interferes with viral replication. So at a minimum, lysine kind of makes sense. I mean, it's not, as far as I know, harmful. It's just an amino acid. You can Google it and learn about it. Rhonda says, really appreciate the time you and the co-authors took to write the book IC 101. I use it as a reference to help in many different ways. And I'm going to be rewriting a part of it probably this summer, and we'll be adding a chapter on sex, because I've got to put the new AUA guidelines in. Just haven't had time yet. But thank you, Rhonda. Thank you. It's a good book. A lot of people are really using it. We were right. Remember, the patients lead the way. 3 years ago, we said IC is not just a bladder disease. And by golly, last year, the AUA, American Urology Association, said exactly the same thing. It's not a bladder disease. We don't think of IC as a bladder disease anymore, except perhaps in patients with Hunner's lesions who have virus. My 3 boys says, can alkaline water contribute to IC? I was drinking alkaline for months because of acid. Yes, absolutely. Absolutely. Because, as my first chemistry teacher taught me, inorganic chemistry, and we had our safety lecture on the very first day of chem labs. And he said, and I quote, bleach will eat your eyeballs out just as quickly as sulfuric acid. And then he explained pH. Sulfuric acid is acidic. It has a very, very low pH. Bleach is alkaline. It has a very, very high pH. But if you've ever spilled bleach on your fingers, what happens? It gets very slippery. Why? Because it's dissolving your skin. The human body does not function with pH extremes. We are not overly acidic. We are not overly alkaline. The human body is basically neutral. And so my 3 boys, absolutely, because what you were doing is you were pouring diluted bleach in your bladder all day. That's why we don't support the use of alkaline water at all. I mean, the only context where alkaline water makes sense, maybe, and I personally wouldn't do it, would be if you went and had spaghetti and it was super acidic. You wanted to try to counteract some of the acid. Then, a couple of pre-leaves, a little bit of sodium bicarb, or maybe a little bit of alkaline water can do that. But drinking alkaline water all day, every day makes absolutely no sense. And I remember there was a company that was trying to sell a product similar to Pre-Leave, and their marketing strategy was to tell people that they had IC because their body was too acidic. Therefore, if they drank alkaline water, it would go away. And they got laughed out of the IC world very quickly. I mean, they came to me, I laughed, and they went to one of my peers who ran a support group in Southern California, who's a hell of a lot smarter than I am, and she kicked their butt just with the science. And they walked away, and they should have. They should have. They just didn't understand it. Your body pH is controlled minutely in your blood. Your pH in your blood is controlled minutely. So anybody who says you're overly acidic, if you're overly acidic, you'd be dead. If you're overly alkaline, you'd be dead. pH is controlled to the thousandth percentile just by mechanisms within our bloodstream. So I don't support that at all. And there was a book. I had a book over there that talked about it. It's out in the garage. It's in my storage unit. Rhonda says, I have my own book, but I'm trying to get my local library to order it for others. Our library knows I'm often looking. Yeah, I'd be happy to send it to them. Sally says, I'm very intrigued by this virus theory because my white blood cell count has been high and they can't figure out why. Maybe it's my IC. It's possible. It's possible. And if you go to the IC Network website, I've got several blogs on it that link to the research studies. So you could print out a couple of those research studies and give them to your primary care doctor and say, you know what, just out of curiosity, can we just do a viral screen? Because I just found out that we have a confirmed link between a couple of viruses and the bladder by our own National Institutes of Health. And I have to wonder if maybe that's playing a role in some of my symptoms. They found polyoma virus, they found Epstein-Barr virus, and herpes to a later extent, mostly Epstein-Barr and polyoma. Polyoma virus is a virus we all have. It's not a sexually transmitted disease. It is part of the normal human biome. It just gets turned on in patients who are immune compromised. So if you are immune compromised, then, for example, patients going through kidney transplant where they're on immunosuppression drugs because you don't want to reject the kidney. That's the perfect circumstance for these more subtle viral infections to get turned on, or patients with HIV, or patients with known autoimmune issues. So the viral theory it's not just a theory, it's fact. It's been found. It's been found in IC patients by our own government. So it is reasonable. Let me look at my website here for a moment. You guys, if you haven't been to the IC Network, did that move that in the right direction? Yeah, icnetwork.org. Come on over to icnetwork.org. And let me just kind of remind myself here, virus. I've written about it a lot in our magazine. Yeah. So just go to our website, search for virus. A common virus could be the cause of IC in some patients. That's from 2019. We also know herpes can intensify IC flares. Here it is. New research reveals viral infections in some IC patients. This was from 2020. So it is 1, 2, 3, 4, 5, 6, 7. It's the 8th link. And let me just read this. I think this is important. There's a small vocal group of patients and clinicians who suggest that IC is a result of a chronic bacterial infection This quote, all or none theory ignores the thousands of patients who have developed urinary frequency, urgency pressure pain after chemotherapy, menopause, fibroid tumors, endometriosis, Charlotte cysts, and more frequently, pelvic floor muscle trauma and injury. That said, chronic infection could be present in a small group of patients. The question, of course, is what type of infection? Bacterial, fungal, and viral infections should all be considered. The premier IC research team in the US, the Multidisciplinary Approach to Pelvic Pain Research Network, was the first to discover that some patients appear to have fungal infections in their urinary tract, especially during flares. Using next-generation DNA urine testing, a second study found up to 13 species of fungus in some patients, and that the more species a patient had, the greater their pain. Fungal growth can happen as a result of antibiotic use. And I argue if there's a group of patients, there's no group more overexposed to antibiotics than us because everybody thinks UTI. However, researchers in Europe made a key discovery several years ago, which also brought viral infection to the forefront. They found the polyoma BK and Epstein-Barr viruses in some patients with Hunner's lesions. Another study used an antiviral medication as a therapy, noting the presence of polyomavirus in IC patients. Yet strangely, though, there is little discussion about the potential role of viral infections in the USA till the MAP Research Network released their first pilot study of viruses found in the urine of some IC patients in the spring of 2020. This federally funded team focused on two families, or on the family of human polyomaviruses, because they are known to cause the development of vacuoles, holes in the urothelium, often seen in IC biopsy results. Two polyomaviruses, JC and BK, have been known to establish lifelong persistent infections in the urinary tract that are also known to be periodically excreted, thus more easily identified in urine. Polyoma BK is also is a known cause for hemorrhagic cystitis in patients who are immune compromised and or undergoing stem cell transplant, proving that the virus can cause disease in the bladder urothelium. MAP researchers studied 50 urine specimens collected from IC patients, 5 urine samples each from 5 men and 5 women from across the country. Urine was collected at baseline, 6 months, and 12 months of clinic visits, with at least one of the samples collected during an IC flare, and the flare and non-flare samples were collected at home. After their preliminary analysis of each sample, researchers created 5 different combined pools. Oh, you don't need to know this. All right. Anyway, they revealed that 70% of participants were found to have polyoma BK DNA in their urine, though not in all samples from the same individual. In other words, it was turning on and turning off. The polyoma JC virus was detected in 30% of participants, but the prevalence in patients was higher. One patient had JC in all of her specimens, another had JC in 4 out of 5 specimens, still another had JC in 3 out of 5 specimens. Only one patient had consistent shedding of the BK virus in 4 out of 5 samples. In all, 12 out of 50 urine specimens had JC and 11 out of 50 had BK. Patients with positive polyoma JC findings had significantly more pain when compared to those who did not have the virus. Similarly, urinary severity was higher in those with JC. Patients with positive BK finding also had more intense pain. In this group of 7 patients, higher pain and urinary scores when the BK was detectable in their urine. JC was detected in 25% of flare samples and 23% of non-samples. BK was detected in 30% of flare samples and 17% of non-flare samples. The study establishes that both polyomaviruses may be present in infected urinary cells in some IC patients. Clearly, additional studies with larger population of patients is needed to determine what role, if any, that viruses may play in IC. This certainly should give pause to those who suggest that IC is a result of a chronic bacterial infection. In fact, viruses could play a much larger role than previously realized. We can't wait to see more research studies on this topic. Bam! That's a damn good article, don't you think? I wrote that article. I got 8 research studies listed in here. I'm going to give you the link. So print this out. Print this out. Take it to your doctor. So I put that on Facebook. For those of you on YouTube, you're on a completely different computer. And so just go to the IC Network website, icnetwork.org, and search for virus. Renee says, will PCR tests show fungus and virus? Yes, but normally they don't check for the virus in the cheap next-gen tests. In the cheap next-gen tests, they just check for fungus. You have to order the virus test separately. All the COVID testing is next-generation viral testing. Renee says, you just got your first magazine after joining the IC Network. Loved it. Oh, I'm so glad. Girl, our winter one is floating around in my brain right now. I've been very hard for me to find a couple of hours to actually write it. That's the work I love doing. I love interpreting science and making it a little bit easier for you guys to understand it. I mean, and this is huge. This is huge. So, do I believe that chronic UTI is real? Yeah, I do. Not for all of us, but for a small subset of us, absolutely. But the question is, what's the infection? And you got those people online saying it's bacteria. You got to take antibiotics for a long time. Guess what? The National Institutes of Health uses the best researchers in the United States, if not in the world. They have looked for bacteria. They have not found bacteria. In fact, the biome studies show that the IC biome with respect to bacteria is entirely normal. But this is what they did find. They found virus. And we're getting a lot of patients being diagnosed with IC after COVID. A lot. My 3 boys, what kind of treatments can be used for acid reflux for people who suffer from IC? Oh, you know what? My favorite, because I have been known to have acid reflux every now and then, is Gaviscon. Let me get a bottle. I'll show it to you. This is what Gaviscon. It was my gastroenterologist, because we have gastroparesis in our family. My dad has it. I have it. We all inherit crazy stuff, right? So for me, I have delayed stomach emptying. My stomach doesn't empty promptly. Food sits in there and it starts to ferment. Thus, I start getting gassy. Then I start to belch, right? And so the gastroenterologist that I went to said Gaviscon. The reason why is because first of all, it tastes great. It's just like, don't get the cherry. The cherry's awful. Get the original flavor. The original flavor is good. It creates a foam that sits on the top of your stomach, and it keeps the acid from going up into your esophagus. There's kind of an art to taking this. We always have it. We always have this on hand. My dad, every day, he gets GERD. If he bends over, he gets GERD. His sphincter at the top of his stomach doesn't work. And I'm constantly yelling at him to stop bending over, but he wants to do the laundry. He wants to do stuff. And he goes, well, I know when you're going to do it, so I'm going to do it. And then he bends over, and then I have to listen to him moaning for an hour, shoving Gaviscon down his throat, basically, until it goes away. It's one of the things I'm a little bit frustrated with right now. It's like, Dad, I will do the laundry. I just can't do it right now because I'm doing a support group meeting, right? Rhonda says, I look forward to the updated IC 101. At least AUA is finally recognizing subtypes. Yeah, I know, right? I mean, nobody can say that the IC world is in a bad place. It's in a great place. I mean, the last year has been phenomenal. The last year has been absolutely phenomenal. The question now is, are the support groups online doing their job of educating patients about it? And that answer is no. I think I'm the only one that's talking about it. I think the worst place you can go right now is, especially if you're newly diagnosed, is to a Facebook support group. Scare the hell out of you for no reason. Because for all we know, you're going to be a mild estrogen atrophy patient talking to a patient with a severe viral infection. Apples and oranges are not the same, nor should you ever expect that that's going to happen to you. So we do have a lot of work now to get this information out, because it's now every international medical group has gone this way in the last year. We are there. We are there, and it's exciting. It's very, very exciting. All right, you guys. Well, I think we have come to our natural conclusion. But I think what I'd like to do, I want to do an experiment here. Hold on. Give me a moment here. What I've decided to do is create mini videos where I'm actually reading each chapter out of IC 101. And so I want to try it. I just want to try it. So give me a moment here. I just have to download one onto this computer. Wait, PayPal says I just sent a payment to Kilo. Who the hell is that? Oh, no. Oh, no. I don't want to do that. I need the PDF file. Yeah, I do not want to open Word. Here we go. There it is. All right. So if you want to hang around, that's fine. If you don't, that's okay too. I'm just going to take the next 10 minutes or so and read a little bit from the IC network. I mean, from IC 101 I'm then going to try to sample into a video. So let me do this. Take one. Okay. Hold on, gotta take a deep breath. I can do this. All right. I have to smile into the camera. Chapter 1 of IC 101, It's Not Just a Bladder Disease, a complete guide to interstitial cystitis, bladder pain syndrome, chronic pelvic pain, and chronic overlapping pain conditions by Gay Grissom Sandler, Jill Heidi Osborne, and Andrew Sandler, with a foreword by Robert Eckenberg, MD. Copyright 2021, all rights reserved. Dedications to June Gripper Grissom, who taught me through example how to live well in spite of chronic illness, and to Helen Osborne and Janice Schmidt. The IC network would not have been built without the support of the women in my family. We have traveled the world representing IC. We have held each other through difficult times, and together we thrive. Acknowledgements. With gratitude for their insights and contributions, Dr. Robert Eckenberg, MD, Sylvie Beaumont, DC, Wen Zuan, MD, Jenny Butaccio, OT, Beverly Lauman, and Rachel Fazio. For every patient who has been told that your symptoms are all in your head, may this book ease your journey, help you identify the cause of your symptoms, and find more effective treatments. We hear you. We stand with you. You are not alone. Foreword by Dr. Robert Eckenberg. I was honored in 2014 to have been asked to write the foreword for Gay and Andrew Sandler's excellent book, The Proactive Patient, Managing IC and Bladder Pain Syndrome. The Sandlers have now, in 2021, collaborated with Jill Heidi Osborne, the founder of the IC Network, to expand upon their previous work with an update focusing more on IC, but still relevant to all the overlapping pain conditions I see daily in my practice of pain management of the pelvic region. I have once again been asked to write a foreword for this current work, IC 101, It's Not Just a Bladder Disease. The science of chronic pain in general and the understanding of the mechanisms of genetic, neurochemical, and biopsychosocial underpinnings of myriads of clinical pain disorders has exploded since the 1990s. Correspondingly, and unfortunately, this wealth of new research has been slow in trickling down to the variety of medical specialists related to the pelvis. On the one hand, this book offers wonderfully detailed and sophisticated self-help for those countless individuals suffering with IC BPS and all the related pelvic pain triggering disorders, as well as overlapping disorders. But I honestly believe it should be mandatory reading for all medical students, residents in urology, OBGYN, gastroenterology, general and colorectal surgery, orthopedics, dermatology, as well as in postgraduate fellowship programs such as urogynecology. Ms. Osborne and the Sandlers remind the reader that it may be challenging to find healthcare practitioners that understand their pain and or even acknowledge that their condition exists. In my own practice, I hear these stories daily. We spend considerable time educating and re-educating our patients about the differences between acute and chronic pain and how the dial needs to be turned down in their central, peripheral, and autonomic nervous systems, along with diagnosing and treating the triggering of that upregulation, treating those triggers, managing the pain itself, retraining the clenched muscles, and rebooting their midbrains not to keep playing that same disturbing, frightening tapes of previous injuries and traumas. It was wonderful to see that this book has not ignored basic clinical chronic pain research and even mentions Dr. Daniel Claw's explanations of chronic pain processing disorders that finally begins to lay out the underlying neuropathophysiologies that explain fibromyalgia and related neuropathic pain disorders. Dr. Claw has been one of my inspirational thought leaders in my own evolving broader understanding of pain. Additionally, strong research findings indicate that our bodies, regardless of race, gender, ethnicity, or belief symptoms, tend to react similarly throughout the world to injury, inflammation, and trauma. And again, this book did not forget to point out the typical fight or flight reactions that are constantly adding to our natural defense mechanisms. We are certainly programmed to automatically and physiologically protect ourselves and our loved ones, even if it might add to our pain and further damage us. Those of us who are parents know that if we are involved in a car accident, somehow climbed out with a severely fractured leg, but our child is trapped in the car, we would not feel the pain of that injury until we saved our child. The same is obviously true if we injure ourselves falling off a curb. But if a bus is about to hit us, we're still able to run from the danger and the pain comes later. Automatically and in microseconds, our nervous system tends to make those decisions for us. In chronic pain, I describe to all of our patients that our tolerance builds gradually in order for us to function with varying degrees of background pain until that dial finally exceeds our tolerance and we go over the edge and feel that suddenly we can no longer tolerate even small amounts of discomfort. Young athletes experience what I call good pain as they play more and more competitively and commonly learn how to play through pain. But unfortunately, many of these young women men suffer later as they continue to, quote, do life through the pain and even have sex through the pain. Long after previous injuries and traumas have healed, our muscle memory and nervous system memory continues to chemically and physiologically remember those injuries and traumas. What then can become the perfect storm may begin to insidiously bring out more and more of these memories, especially if common functional, irritating, and often inflammatory disorders are also present. Thus, in the pelvic region, we're talking about IC, pelvic endometriosis, vulvodynia, pudendal neuralgia, vulvar vestibulodynia, and pelvic floor dysfunction, all of which are so much more common than we had ever thought. All these disorders, along with multiple autoimmune inflammatory disorders, are the reasons so many young women flood to their gynecologists and primary care physicians and are so commonly misdiagnosed with chronic vaginitis, most commonly yeast infections, recurring ovarian cysts, and UTIs. Truly, everything is connected when it comes to what is now beginning to be labeled chronic abdominal pelvic pain syndrome. I would add to that genital pain syndromes as well. Simply put, to best diagnose and treat these tens of millions of young men and women in the USA alone, it requires an overview of the whole person, and it's best done in a setting that is multidisciplinary, multi-organ, and involves multimodal therapies. Ever since I became interested in pursuing the management of chronic pelvic pain disorders over a decade ago, following over 30 years as an OBGYN, I became aware very early that the bladder pain syndromes were somehow at the core of the core related to almost all of these abdominal, pelvic, and genital pain diagnoses. I first concentrated on figuring out how best to diagnose and treat IC. Dr. Fred Howard from the University of Rochester, a founding member of the International Pelvic Pain Society, wrote an article in one of our journals in 2011 in which he pointed out to all gynecologists that 80 to 85% of women with chronic pelvic pain have IC BPS instead of or in addition to a gynecological reason for their pain. I've had that same experience over 20 years. I estimate that I've diagnosed and treated more than 12 to 1,300 women and men for IC for at least a significant portion of the triggering of their pelvic pain regional areas issues. Another one of my inspirational mentors over the year who helped me advance the pain management aspects of IC-BPS has been Dr. Dan Brookoff. I remember the first time I heard him speak at a pain conference. Dr. Brookoff was a medical oncologist and pain management expert for cancer patients for some time. He recalled in his talk how he became interested in IC when a female audience member approached him following a talk on cancer pain and asked him to care for her IC pain too. He declined, saying he was not a urologist and didn't know about IC. She persisted in asking for his help and finally told him she wished she had cancer so that he would treat her in the same way he had described treating his cancer patients. I began regularly corresponding with Dr. Brookoff, who was always eager to share his knowledge with anyone who cared to hear. He even sent me an unpublished manuscript of a new paper he had written on chronic pain processing and bladder-related pain. When I asked him to write the foreword of my own book, Secret Suffering, How Women's Sexual and Pelvic Pain Affects Their Relationships, he immediately agreed and did so. And I'm still very grateful to have had that collegial relationship with Dan before his untimely passing a few years later. In closing, I feel that this book, IC 101, It's Not Just a Bladder Disease, should be read by all patients and their caregivers who wish to learn more about IC, including all the extremely helpful personal hints, guidelines, and references that fill so many of its pages. In addition, it covers diet, nutrition, manual therapies, overlapping illnesses, chemical sensitivities, sexual and life cycle variables, and more in a comprehensive manner, certainly not typical of the various previous publications on IC. and it will surely be on the reading list for all of my pelvic, genital, and sexual pain patients. History has often shown that advancements in women's health issues commonly arise from women's own increasing knowledge of their bodies. Providers eventually respond to the demands of their most informed patients. Sadly, as far as these issues are concerned, and even now in the 21st century, patients still need to become as informed and proactive as possible. My hope is that this book will allow each of its readers to explore many different solutions to earlier and more effective care. Signed, Robert Eckenberg, MD, at the Institute for Women in Pain. That's www.instituteforwomeninpain.org. That is all I can read because now my throat is on fire. So I have to stop there. But anyway, that's the foreword for a book, IC 101. It's not just a bladder disease. If you would like to get that, come on over to the IC Network website, icnetwork.org. Or you can get it on Amazon also, and it's also an ebook everywhere. All right, guys. I gotta go. And hey, Amy says she's gonna try to call me tonight. Hun, don't call me tonight. I have to go cook for my parents now. Try calling me either tomorrow afternoon, although Mondays are my day off, or Tuesday. Okay, but my voice is done and now it's hurting, so I gotta stop. All right, guys, I will see you later. Be well. Facebook, you might see me on Thursday, providing things get better. Otherwise, I will be here next Sunday. And please remember, you're perfect just the way you are. You have done nothing wrong. There is no shame or no blame. You're just hurt. And we're going to figure it out and get you better. All right? All right, my friends, I wish you well. All right, I'm going to say goodbye to YouTube first. All right, bye, YouTube. See you later. See you later. See, now I'm going to be hoarse.